All right, everybody, 6 o'clock, Thursday night. You know what that means. It's time to do some learning. Um, Tonight we have Laura Holdren. She's the EMS coordinator from Nationwide Children's Hospital in Columbus, Ohio, and she's going to be talking to us about the special health care needs or caring for children with special medical needs. Um, Obviously, a tough call to be on, especially when you're working on kids that already have problems and you might not know what's going on or anything like that. So hopefully she's going to give us some insight. Um, Once again, I want to extend my thoughts and prayers to anybody whose EMS family is going through the craziness with this COVID-19 and with the sickness and deaths we've been having in our family. It's kind of rough. But on the other hand, I'd like to give a little shout out to a couple of people that have been participating. I'm not sure if they're all on today, but I happen to read in the paper. I live in Canfield, and I happen to read in the paper that the Cardinal Joint Fire District had some people given some awards, just local awards and everything. But it's always nice to see that somebody gives a crap and gives an award and a little bit of recognition. So I'd like to give a tip of the hat to Colin Dales and Jillian Smith for their life-saving efforts on a gentleman. They recognized a serious injury where the kid was probably going to lose their arm if they did not intervene correctly, and of course they did, and did a great job on that particular patient. Additionally, Todd Baird, Bill Wilkinson, and Al Ravalski had a call where they were on their way to another call and happened to notice got flagged down for cardiac arrest and were able to save the man. And I think that's awesome. We all run these calls all the time and everything, and we don't always get recognition. But when we do get recognition, it's nice to have a little tip of the hat. So good job, guys, ladies and gentlemen. Good job. I appreciate it. As a person who lives in Canfield, I appreciate it. After Laura's done, I'll be talking to you today about infectious diseases. Dr. Musali was not able to make it, not through any fault of his own. So you're going to have to listen to me for an hour. So lucky you. Looks like we're getting a pretty good group in here tonight. There's still some people signing in, but we have to get started. So we're going to get started. I do ask that, in the future, think about trying to get on a little bit earlier, because the later we start, the later we get done, it seems. So without further ado, here is Laura Holdren, Nationwide Children's Hospital EMS Coordinator. Take it away, Lauren.
Hey, everybody. I'm Laura Holdren. I am the full-time EMS coordinator at Nationwide Children's in Columbus. I am also the full-time EMS educator. I have 2 part-time EMS educators and a EMS physician that work with me. I feel like it's kind of some days it feels like a lot, some days it doesn't feel like so much. We're going to talk a little bit about taking care of kids with special healthcare needs. If you guys have any questions, I might have to have him read the questions aloud because I'm on my laptop, so I can't see the question as well in the chat. But this is an open learning forum. This is for your benefit. So if you guys have any questions, if you guys have any cases that are relevant, please feel free to share. Not now, we'll have some time for Q&A at the end. This talk tends to be a little bit long, so hopefully everybody had their coffee. It's all nice and settled in. So I'm going to start off with the noggin jogging, right? I like doing some noggin joggins to make sure you guys are all up and paying attention. So you guys receive a call to respond to a local preschool for a 4-year-old who had a seizure on the playground. You guys arrive to scene, bystander waves you to the playground area. You see a child laying on the ground, eyes closed, with a caregiver sitting next to the child. So caregiver states that the child stared into space, then fell and hit her shoulder on the playground equipment and started shaking. So you guys going through your assessment. So witness seizure, medical history of epilepsy, takes carbamazepine twice a day. You guys do your assessment. Shoulders has a reddened area, eyes closed, opens eyes briefly to tactile stim. There's your vital signs. Lungs clear, pupils sluggish, but equal and reactive to light. Treatments and transport. What are some things you guys might start thinking about?
Oxygen.
I agree, right? So I have, apply oxygen, pulse ox, capnography, things like that. Check glucose, trauma assessment, check C-spine because she fell and hit playground equipment. Potentially be prepared to manage airway, safe transport. So if they had a seizure, they could have another seizure. So maybe get them in a position of comfort, position of safety. Being prepared to manage airway doesn't necessarily mean like ET tube. What if they start seizing, if they have a lot of secretions, if they start vomiting? And then think about what kind of medications you would be prepared to give this child if they started seizing on the way to the hospital. So I know you guys have another run. You're like, man, I picked the wrong squad today, right? Got two pediatric patients, and both of them have some medical issues going on. You guys receive a call for a 10-month-old child with a history of bronchopulmonary dysplasia, whose caregiver stated that the child is not getting enough oxygen with their ventilator and they're congested. The kid normally only uses the ventilator at night, but has been using it for the past 24 hours straight to maintain saturations above 90%. So you guys go in to do your assessment. So, congested, possible ventilator problem, medical history, bronchopulmonary dysplasia, tracheostomy, congestion for 2 days, vomited once after their tube feed an hour ago. The ventilator alarm's beeping. The child appears anxious, pale, thick, cloudy secretions coming from their tracheostomy. You got some vital signs? What would you do if that was your call?
Suction.
Yeah. Does it say suction? Oxygen, maybe you have to bag the kid, ventilator's beeping. Is it malfunction or is the kid just really congested? Maybe a high pressure alarm? You're not sure? I say you suction, caregiver tries to reconnect them to the ventilator, tries to troubleshoot some more, continues to alarm. Say, apply oxygen and assist respirations with a bag, right? You don't have very much time to mess with the ventilator if the kid is having trouble maintaining SATs, looks anxious, there's some signs of respiratory distress. Transport the child, ultimately would like to transport to pediatric hospital, but if your local ER is the closest to help get things handled, they absolutely, they have ventilators, they've got respiratory, they've got physicians. Some other considerations is to bring their home ventilator. You got two reasons. One, it's a lot easier to troubleshoot that ventilator after the child is hooked up to a functioning hospital ventilator. And two, thinking about this child and family, how are they going to get home? Most EMS agencies don't make round trips. So if they can troubleshoot that ventilator and get it fixed, a lot of these children go by car home, especially 10-month-old. They can tolerate being in a car seat. They can have battery pack on the ventilator or have a cigarette lighter adapter. So, one more. Third call in a row, right? So you guys receive a call for a 7-year-old child who has had a fever and will not stay awake. Child has a history of acute lymphocytic leukemia and port placement. You guys go in, do your assessment. Fever at home, sleepy, won't stay awake since yesterday, refused dinner. Had chemotherapy 4 days ago, last dose of antibiotics yesterday, takes daily prednisone and allergic to vancomycin. They're opening their eyes to tactile stim. They kind of mumble and go back to sleep. Their hands and feet feel cool to touch. Their torso feels warm. Their face is flushed. Their lungs are clear. I got some vital signs. You got some red flags going up there? I got a kid who's got a temperature, but their extremities are cold.
Yeah, that's a bad sign.
That's right. And you've got a kid they've got leukemia, they take prednisone, they're taking chemotherapy, so they're immunosuppressed. So a small infection could be a big deal to this kiddo. So they apply oxygen, ask the caregiver for the best place to start IV access. Your partner is able to place a 22 gauge IV in the right arm. Secure the child and begin to give some fluids. Get them on the monitor, right? About how much fluid should you guys give for pediatric patients?
20 per kilo.
That's right. What do you think is going on with this kid?
Most likely septic shock.
Yeah, I'd say, and they're immunocompromised, so unfortunately for them, the infection kind of went pretty bad pretty quick. So transport destination, ideally, if possible, get them close to where they get their treatment or where they get their treatment. If not, it's telling the local community hospital, giving them a good report and letting them know any additional information, like the fact that they have the port, because that could be a source of infection, and where they get care. So there's your objectives for today's lecture. I know I put the noggin joggins first. You guys can read your objectives to yourself. State of Ohio said we have to have them for CE, so please don't come for me, State of Ohio. A little bit about children with special needs and EMS education. The state EMS for children recommends that every agency adopt protocols to take care of children with special healthcare needs. Providers might need some additional instruction for underlying conditions and treatment recommendations for these kind of kids. Epidemiology of kids with special healthcare needs. 1 in 3 children with special healthcare needs had at least one ER visit in the past year. And 1 in 5 kids missed more than 7 days of school in the past year due to illness or injury related to their special healthcare needs. It's a huge term, kind of catch-all term. There's different degrees of activity limitations, how well they can function. It varies by what they've got going on. Why do we see more kids like this cared for at home? So there's a change in societal views. Early on in my healthcare career, I was a patient care assistant at a place in Columbus, Ohio called the Heinzerling Foundation. And the Heinzerling Foundation was a facility that took over where some people had been placed in asylums because they had physical and cognitive disabilities. Part of the views in that time were that, that these people needed to be in a hospital or an asylum. The parents shouldn't bother to raise them because they just can't handle it. But, now we favor family-centered care. And we've found out that helps. When these kids grow up in a home environment where they can explore their world, they can bond with their family, that gives them the chance to live up to the maximal potential. And some of them may have more potential than their diagnosis would originally allow them. Managed care, some of that stuff can be financially driven. It's super expensive to keep somebody in a hospital. Having a medical home is important. Sometimes to take care of these conditions, people have to drive really far away. Plus, we're in the middle of a COVID pandemic. Do you really want to take somebody who's immunocompromised and have them in a hospital or a large nursing home right now? They're actually less likely to get infections at home. Dr. Bubbles talked before, and she's got a lot of cardiology background, and she said, a lot of the kids that stayed in the hospital longer with their congenital heart disease died of infection. Why? Because hospitals are germy, right? Advances in medical technology are a super big deal. We've got more and more portable equipment small ventilators that can run on battery packs so people can go in regular cars, backpack pumps for feeding tubes so people can get their tube feeds but be out in the community. You know, having that is super wonderful for children, because what do they normally want to do? They want to explore, right? So family-centered care, it's a critical component for kids and youth with special healthcare needs. The community should be evaluated so that it can provide those resources and support to care for the child at home and support their family. And part of that's where you guys come in. You know, you guys are part of that planning, having that family-centered care. Also, you know, EMS has a huge role in disaster planning. You know, I brought up what would happen if you guys had a flood in your area. What if you had an extended power outage? You know, what is your community plan for somebody who might be ventilator dependent or oxygen dependent or need batteries or electricity to operate their feed pump? And do you guys have them into your community disaster plan? Like, where would they go? There are places with a generator to plug them in, you know, local hospital, community center. Emergency information form. This is a form I did not make, but I see them a lot. ASAP and American Academy of Pediatrics made this form just to kind of do a little bit of a quick and dirty for EMS, to give them some things, you know, about the child, including their primary diagnoses and what their specialty physicians are. While we're at Children's and have lots of specialty physicians, you know, if you're in a smaller agency with a community hospital, you may not have a pediatric cardiologist, but you guys might have a cardiologist, right? And they can speak cardiology. So if you have to transport that patient, it's important to hand off, you know, if you find out that information that they need a special cardiology assessment, because their cardiologist can, you know, potentially talk to a pediatric cardiologist from that child's clinic and start appropriate interventions. They may not even have to be transferred out of their local area. They may be able to get those interventions close to home at the community hospital and be able to go home. Special needs considerations. I actually love this guide. Not all of them are pediatric considerations. It is the mobile tips for first responders from University of New Mexico. You can look that up and save it on your phone. It has some interesting like quick tips when you're going to those houses, you know, people with how to deal with somebody with a service dog, how to help lead somebody if you have to have them walk somewhere if they're visually impaired. So, tips for talking with children and their families. Combat your unconscious bias. So you may see different types of families, different types of kids with special medical conditions. You may not be accustomed, you know, to working with people like that. You know, you may be like, I'm not comfortable with this. I've never seen, you know, somebody with this condition. So you want to be aware of yourself and don't assume anything about anyone in the family. You know, find out. You may have a child with a physical disability, but they can hear and understand you. So, you know, if you know, don't assume that just because they're in a wheelchair, they can't understand you, or even assuming anything about the family. We have for these kids to go home with things like ventilators and feeding pumps, the parents, grandparents, and even the adult siblings will go to CPR class. They will do 24-hour care in the hospital after taking some education and training so they can bring their family member home. And they may not even have a GED, but they will know everything about their child's ventilator because that's what they have to run all night, every day. So, you know, assume team mom, team dad, or even team grandma, whoever the primary caregiver is. Talk to them, ask them good questions. Considerations, you know, is it medical condition versus equipment malfunction? It may be super overwhelming if you go see an infant. that has a ventilator, it's got a feeding pump, has suction, has all these things around them, you still need to treat the child. Ask for baseline vital signs. Things like congenital heart disease, while these kids are in those stages of being, going to kind of rewire the plumbing so they can get that blood supply to their heart, their baseline might be 86%. Different size, different developmental levels. Long-term hospitalizations may make it harder for them to hit their milestones on time, and simple illnesses can be life-threatening. Team dynamics. I don't know, anybody taken CPR recently, right? Both before and while you're taking care of these kids, think about your team dynamics. Your clear messages, your clear roles and responsibilities. Uh-oh, somebody's beeping.
Hello.
If somebody has a history
Okay,
of going to that child's house, like, hey, I've been to this child's house before. They normally grandma takes care of them at night. They normally have this equipment in the home. So mutual respect includes active listening. What could you have missed? Is there something that a member of your team knows? Is there something that one of the family members know? Could that idea improve their situation? So family, like I said, lots of puzzle pieces with the family. And since I work with pediatrics, I like to remind everybody that you don't normally encounter the child by themselves. You've got family members, even from small to large. Might have auntie, uncle, cousin, siblings. So developmental approach. Adding one more level, right? You're assessing kids. Think about the age and developmental stage of the child. What ages would benefit from sitting on a caregiver's lap for their initial assessment? They're stable. And you think about your infants and toddlers that might have a little bit of stranger danger. What ages might think that illness or injury is some punishment? Okay, I didn't brush my teeth last night before bed like my mom told me to. And so I fell out of the tree and broke my arm today because I was bad yesterday. That magical thinking of those younger kids. And how do you approach a teenage patient? Possibly with a chair and a whip, like a lion tamer. I'm just kidding about that. Teenagers want autonomy. They don't want to be perceived as a baby. So there's my chart on developmental. So it kind of breaks it down. It's super tiny, so it's probably not the easiest thing to see. But you think of infancy, they want to see their parents. They don't like being cold. They've got stranger anxiety. Through your toddlers and your school age. So change that perspective. Start out with what you know. So your pediatric assessment triangle, everybody knows this, right? Now look at that child from the door. Do your ABCs. They're sick versus not sick. Stable versus unstable. So we got the kid that looks sick, can't even open their eyes to look at you. You've got the other one that has already taken your stethoscope and is doing an assessment on their doll. Their work of breathing. When you're treating the child versus the technology, I've got this kiddo. It's like they've got tracheostomy to cool mist collar, right? Might have not expected that if they didn't give you that information before, but what are some things that you can observe about this child? I think their color's appropriate. They've got tone. They've got good tone. They're making eye contact with their caregiver. They look relaxed. Circulation. How do they look? A little bit more difficult on those cold days, but you want to check when these kiddos are warm. This child has some foot contractures. They look a little bit mottled, but is that normal to them? Respiratory considerations. Infant apnea can be 20 seconds or longer. I don't think I could wait for 20 seconds to see if the kid was going to breathe again, but infant apnea can be caused by anatomy, prematurity, genetics, or neurologic conditions. So they may grow out of that. So that apnea of prematurity, it's because that respiratory center is underdeveloped when they were born early. Things that you can expect, they may have an apnea monitor, they may have oxygen, CPAP or BiPAP, medications like caffeine or theophylline, or a tracheostomy. So your home interventions with respiratory, got this kiddo that's on a ventilator at home. If you look, they've got it plugged in and then they've got their little supply cart set up. An apnea monitor set to alarm. Home oxygen therapy in children. It may be temporary or long-term, and they adjust this in very small concentrations. One, because they're kids, they've got small lungs, they're trying to wean them off, and sometimes they just need that little bump of oxygen. So they may only be on a half a liter consistently, but that half a liter makes all the difference. So if they have home oxygen, ask the caregiver, what is their oxygen order at home? And if they're on it continuously, put it at the settings, start off with the settings that they have at home and then titrate it slowly. CPAP, that continuous positive airway pressure, used for sleep apnea, infants, former premature infants with immature respiratory tracts, kids with neuromuscular weakness, tracheal malacia. Oh, that was loud for a second. Which would be where the tracheal rings don't form completely. So when the child, coughs or cries, their airways can just snap shut. And chronic pulmonary edema. So their pulmonologist will have the type of machine and have settings. They use these more and more because they've become, one, smaller and less costly, but it also can prevent these kids from needing a ventilator or a tracheostomy. Could be used continuously or just at night and during naps. BiPAP, that bi-level positive airway pressure, so it's a higher level on inspiration and then a lower level on expiration to reduce work. Masks look similar, and of course their settings are determined by their pulmonary team. Cough assist, so it blows air in and then pulls it out. It's helpful with kids with frequent lung infections, weak cough or weak muscles, kids with muscular dystrophy, kids with paralysis. These can be very useful too. This kiddo is holding one that you would put up to your face. They do have a tracheostomy adapter. If there's a child with a tracheostomy, and then they can use the cough assist at home. Tracheostomy for kids with needing that ventilation, there's multiple reasons for that. Respiratory insufficiency, subglottic stenosis, neuromuscular disorders, bronchopulmonary dysplasia, paralysis, and many other conditions. They could have ventilator, oxygen, or be breathing room air. At this little infant with their tracheostomy connected to their cool mist collar. The anatomy of a tracheostomy tube, either you're super confident with trachs or you really hope that that's not your run, right? One big thing, that picture in the middle is probably what you're the most accustomed to in the adult world. You've got your tracheostomy tube with the internal cannula and the obturator. And then underneath that in that blue box is a cap. So if they were intermittently capping, if they were going to wean somebody from the trach. Got the picture of where it goes. And then on the other side, I've got some pictures of some single lumen pediatric tracheostomy tubes. Troubleshooting tracheostomies, you guys remember from medic school, the dope mnemonic. dislodgement, obstruction, pneumothorax, or equipment failure. So airway clear, suctioning the tracheostomy. Ventilators, talk to the family, transport the ventilator with the patient, find out what their go bag is. This child has all their supplies.
All done with their black on.
And their go bag. So they've got their oxygen, bag valve mask.
I have to go pick out my outfit for our press conference. Oh, what time was that again?
Home ventilators, multiple reasons: inadequate respiratory drive, weak respiratory muscles, C-spine injuries. They may only need ventilators while they're sleeping. I see it more commonly when kids with muscular dystrophy are home. They may be able to use BiPAP or oxygen during the day, but they may not have enough respiratory drive at night, or it may be too weak. So ventilator, I said, if the ventilator malfunctions, bag them, right? If you're unable to ventilate, obstruction might be occurring. How long will it last? I brought up with your emergency management, it depends on the settings for the ventilator and the model. So if you need to transport somebody for disaster reasons, or find out if somebody can be at their home longer, do they have backup battery, backup generator, car battery adapter? Before bagging kids or suctioning, check for things like the obturator. Hopefully you don't see those because the end of the cap is orange now. Got the toddler in the blocks with that blue thing on the end of her tracheostomy. That's a passy mirror or a speaking valve to make noise. And then up above that is a humidity filter. So what they do is when the child doesn't need to be continuously connected to oxygen or a ventilator, and it's a cold, dry time of the year like now, the little paper in the side will help filter out particles, but it also help keep some of that humidity and warmth in there. But then the child can still breathe in and out. Other emergencies, false track. So if you look where the tube is going, it is actually going under the skin and not into the trachea. I asked our ENT how common this is. They said it's more likely to happen with a new trach than an established trach. So if you went to apply bag valve mask, he would have difficulty ventilating and probably start having some subcutaneous emphysema. So tracheomalacia, like I mentioned earlier, that those immature tracheal rings, they have that severe narrowing on expiration, and even snap closed if they're coughing or crying. Interventions, I said your dope mnemonic, obstruction, clear, change the tube, have those supplies at the bedside, or when you load that child into the truck, ask the parents what their go bag is. So what is their go bag? Typically with things like feeding tubes or tracheostomies, the family will have that bag of supplies that goes with them everywhere. Super useful. And they've got that spare tube. If it's a cuff tube, you want to have empty syringe and bag, suction kit, saline. So onto feeding tubes. Go through the nose, mouth, or through the abdomen. They've received medicine, water, and food. Into the stomach, duodenum, or jejunum. Liquid nutrition is adjusted by the physician in nutrition. Patients requiring the feeding tubes can't meet their nutritional and fluid needs long term. So nasal feeding tubes, pretty common. Infants that were premature or infants with congenital heart defects. A lot of times just the work of feeding tires them out so much they can't get enough calories. Other medical conditions as well. Sometimes they will have that nasal feeding tube and transition to an abdominal feeding tube at a later date. Abdominal feeding tubes, you've got the standard pediatrics, it's a lot more common to see the low profile feeding tube. The low profile feeding tube, the benefit of that is you don't have that tube hanging out, and it may be a little bit more difficult for the child to pull out. So you think about what toddlers would do if they had something sticking out of them, with that low profile feeding tube, they could put on, have that when it's not connected, put a bodysuit or a little abdominal binder over. And then the child can explore without that tubing getting caught. So their feeding tubes, they may be getting, their metafluids with gravity. So I've got the infant in the infant seat, they're receiving a gravity feed. Attach the syringe on, give them their food, their fluids, their medicine. And then I've got 2 examples of pumps. The first one is your kangaroo pump, and then the second one is a backpack pump. Complications with feeding tubes, obstruction of the tube, malposition so they could pull it out, perforation of the intestinal tracts or stomach, displacement of the feeding tube, accidental tube removal, breakage, erosion, ulceration, and necrosis of skin and mucosa, obstruction, diarrhea, aspiration pneumonia. If you think about it, they're getting everything via tube. Hyper and hypoglycemia. So if that tube is obstructed or broken and they're not getting calories, if they're on a continuous drip for several hours a day, they would be very prone to being hypoglycemic. Plus, the site of the tube could get infected. So while EMS do not typically put any food, fluids, or medications in a feeding tube, when you do your EMS assessment of that child, when you're going to listen to lung sounds and checking that child out, look at the site carefully and make sure that that's not part of the problem. Complications, they could have a leak around the tube and site irritation. A leak around the tube could mean a lot of things. It could be malpositioned. It could be that there's some kind of obstruction in the GI tract. Could be infection. So examples, you've got one where the feeding tube's been pulled out. And then we've got on the other side, the feeding tube's connected, but it looks like you've got some kind of like breakdown or ulcer there. And that could be a source of infection. So complications, check if they have any abdominal tenderness. It could be any kind of infectious process and even a peritonitis, diarrhea from infection or complications of maybe allergic to formula, leaking or bleeding at site or accidental tube removal. You're going to cover that with a dry dressing. Broken tube, if a part of it's broken off, you could clamp the end so it's not leaking. And then aspiration, they may be at higher risk for aspiration pneumonia. One, kids, they could aspirate a little bit easier. But 2, if they're not used to taking things by mouth, so you want to assess their lungs and breathing. So, treat them for hypoglycemia per your EMS protocol and check for signs of infection. On to seizures. I gave you guys kind of a little bit of a noggin jog at the beginning. Those episodes of sudden abnormal electrical activity can cause changes in behavior, sensory perception, and loss of motor control. Newborns and infants can be a little bit more difficult to notice whether or not they're actually having a seizure. What's really common would be eye deviation or fluttering, lip smacking. They may bicycle their extremities, and that's going to be more rhythmic, because think about newborns and infants, they are kind of wiggly, right? But in this case, they may have that bicycling, that rhythmic behavior. Sometimes they'll just have the eye deviation and they'll be rigid or only have just a little bit of shaking or fine motor tremor. When you get into older kids, they look more like what you would expect with adult seizures. So, what do they look like? You've got your generalized shaking of the upper and lower. Those focal seizures may just be one side, one part of their extremity, and then, complex partial, they may be confused. They may be appeared, picking at themselves, distracted, or moving really oddly or almost robotically. So, getting that history, do they have a history of epilepsy?
Probably. Grandma's, but now we got lights under the mics on.
And then, does this seizure look like their seizures that they had before if they have epilepsy? Has there been any trauma? Do they have any other medical problems? Are they diabetic? Have they been sick? Have they traveled? Is there a possibility they could be pregnant? I know we work with peds, but we cross over into adolescents. So, what other history do you need? How old's the patient? How long was the seizure? What did it look like? And how many seizures did they have? And what were they doing before the seizure? Did they have any signs of trauma? Are they taking any medications? Are they using any kind of illicit drugs or prescription drugs that don't belong to them? And did they return to normal before having another seizure if they had more than one? That means have they gone through, gotten out of that postictal state and returned to normal and had another seizure? Or did they stop shaking, kind of look sleepy, and then start shaking again? Seizure treatments. Hey, we're at febrile seizure season, I'm telling you, with the flu and the COVID going around. If you have a child that has had a seizure and is febrile, attempt cooling. You want to do passive cooling if at all possible. Take off clothing and maybe just cover them with a sheet. You don't want to aggressively, get them really wet and cold because then they can shiver, and that doesn't really help them at all. The ABCs, acetaminophen and ibuprofen if it's in your protocol. Check a glucose and treat that per your protocol. Benzodiazepines, follow your protocols for diazepam or midazolam or whatever you got, right? So diazepam, families may have that at home. If anybody's seen the Diastat for home use, which would be a rectal gel. So if the child has a breakthrough seizure, the parents are supposed to pull down their pants, put the applicator in, and give them rectal diazepam, lorazepam. They may be prescribed that, or that may be in your protocol. Midazolam has a more rapid onset, at least from our perspective from Nationwide Children's. This is something that has been more favorable to send parents home with, is the intranasal midazolam kit. It's a lot easier to teach the parents that if the child's having a seizure, for them to give them the midazolam via nasal route versus telling them when they're having a seizure to pull down their pants. So status epilepticus, think about 2 or more seizures without recovery. So they're not going out of that postictal stage and back to their normal self, or a continuous seizure of 20 minutes or more. We're really going to be concerned, right? So airway patency, breathing, circulation, disability, check glucose, and give them that anticonvulsant therapy that's on your protocol. So hypoglycemia and seizures. Hypoglycemia is a common cause of seizures. And we're in peds world, so a lot of times these kids, that's when, if they're new onset diabetic, they may be hypoglycemic. Giving dextrose may stop the seizures. Seizure management, consider dextrose if they've got low sugar. Other considerations, special diets. I know we're here right after the new year, and everybody's thinking about their New Year's resolution and getting buff, and keto stuff is popular right now, right? So ketogenic diet for epileptic patients is stricter than Atkins and these other ones that you might be trying out for your New Year's resolution. These ketogenic diets may reduce the frequency of seizures for up to 50%, and that child consumes very little carbohydrate under a strict diet. This is medically supervised. This isn't that they're just trying it on a whim. It's typically they work with their neurology team and to get their medication regimen, and they start on this ketogenic diet. If the child changes their diet, they could have increased seizures. If they're on that severely carb restricted diet, they could have an increased risk of kidney stones and constipation. So recruit the caregivers, ask if they have, any food allergies or if they're on any kind of special medical diets. Check a glucose on these kids, but if they change their diet, we've had the holidays, so maybe they're trying something that's not theirs because it's the holidays, or they go back to school. Kids get older, they start getting a little bit more rebellious. Maybe they want to try their classmates' lunch instead of what they're supposed to be eating for their ketogenic diet. So that could actually cause them to have an increase in seizures if they're no longer following their medical diet. Shunts, vagus nerve stimulators, and implanted brain stimulators. Those are medical devices that children may have to manage seizures or prevent seizures. Implanted vagus nerve stimulators, things that you would want to know. It's currently used in kids as young as 4. And the device is implanted in their left chest, and the electrodes are wrapped around their vagus nerve. Their neurologist may program them to deliver a scheduled daily amount of vagal stimulations, and they will have a stimulator magnet. So if the patient starts having a seizure, their caregiver can stimulate that vagus nerve to give them some stimulation, and that can potentially stop them from having a seizure. So about 8 to 10 people, 8 in every 10 people that have a vagus nerve stimulator say that it improves their quality of life by reducing their seizures. So here's a picture of what it would look like. So you've got that thing wrapped around the vagus nerve, and then the little battery pack and the stimulator switch is implanted under their skin. I don't know if anybody's ever had to activate one of these on somebody before or is more familiar with them. It's interesting enough that if you've ever had to slide the magnet over the implanted part, you will actually see where it's wrapped around their neck. You can actually see their neck kind of twitch a little bit. So look for medical alert jewelry, recruit caregivers to find out more about their device. And if they have a vagus nerve stimulator, if the stimulator is not stopping their seizures, it is okay to give them seizure medications per your EMS protocol. Additional considerations with seizures: patients less than 6 months should be evaluated in the ED, even if they look good after having a seizure. Why? They have a high rate of electrolyte abnormalities and metabolic disorders, brain malformations. They're less than 6 months old. I don't know if anybody has had a baby in the last couple years, but if you are doing okay, they kick you out of the hospital pretty quickly. So these kids, they're born, they're feeding well. Their parents may not know that they have some kind of genetic or metabolic anomaly. They have a seizure. High risk of child abuse. Difficult thing about doing any kind of pediatric run is that you always have to have in the back of your head, could this be child abuse? Kids under 6 months, that's a maybe. They may not have any external signs of trauma, but they have a first-time seizure with a history that doesn't make sense. Consideration: seizures and trauma. They've got, signs of trauma, initiate spinal precaution, spinal motion restrictions. If there's any chance it could be child abuse, initiate C-spine precautions. Since we're talking about special needs, So we definitely have some different seizure clinics, and there are some now, because of imaging and genetic testing, they find that there are some more seizures that are a little bit more harder to treat. Polymicrogyria is a congenital anomaly that affects the folds of the brain. So these kids may be dyslexic or autistic at baseline. And often because they have this abnormal folding of the brain, they can have these difficult to treat seizures. So they capture the structures, they do some electroencephalograms, and they definitely have some different seizures. So, treatments, they're symptom-based. So they typically have a seizure action plan, and then would be calling you if their home action plan is not working. They may be resistant to drug treatments if you've given them what is allowed by your protocol and the child has really been seizing for a while. Consider calling medical control to see if you can give them another dose. So here's some images of that polymicrogyria with that abnormal brain folding. Hydrocephalus. About 2 in every 1,000 babies could be born with hydrocephalus, multiple causes. Some of them would have to do with some congenital anomalies like Chiari malformation or Dandy-Walker syndrome, neural tube defects, meningitis, head injuries. Brain tumors can cause hydrocephalus. What does it look like? So you've got your ventricles, you've got that cerebrospinal fluid. Brings sugar to your brain, right? That's important, but it also has to drain out. You can't have too much fluid because your skull's hard. You don't drain some of that fluid, the pressure doesn't have any place to go back to your brain, right? Start to get that CSF buildup in the ventricles, got that blocked flow, too much pressure. So signs and symptoms and assessment, poor feeding. They might be vomiting, they might be sleepy, bulging fontanelle. I've got your picture of your fontanelle. That if you've got a kid that you're assessing on your EMS run and it's a child under 18 months old, you're going to rub their head for luck like a troll doll, right? You guys remember the troll dolls with the hair that sticks up? Or really,
Oh yeah, I got lots of them.
you're going to rub their head though, right? Because they've got that anterior fontanelle that you can see in that picture, that soft spot. If you rub your hand across the top of their head lightly, it should be soft and flat. If it's sunken in, we're going to be a little worried that they're dehydrated. If it's bulging, something is causing too much pressure in their head, right? They also have a little posterior fontanelle. When you're rubbing your hand across that baby's head, when you're rubbing their head for luck, in the back towards the occiput, they'll have that posterior fontanelle, but it closes by 2 to 3 months. Kids will be irritable. They might have seizures. They might have sunset eyes. Other signs of increased intracranial pressure, irregular respirations, pupil changes. Eventually, they may be dilated and unreactive. We don't want to get to that point, right? Your complications for that would be brain herniation and death. You want to follow your protocols for any signs of increased intracranial pressure or bulging fontanelle, right? Because that's one of your first signs. So hydrocephalus, some interventions. This kid had a ventriculostomy, so it's going to create that space for the CSF to drain out of the third ventricle, and a cerebral shunt placement. Here's an example of your cerebral shunts. The ventriculoatrial, they would actually drain it into the heart. A lot of times they use that as a temporary measure. What you're most likely to see is that ventriculoperitoneal. So it'll go from the ventricles of their brain behind their ear, which you may notice a C-shaped scar or kind of like a C-shaped bump behind their ear. And that would be where that catheter comes out of their skull and goes down their neck, goes into their peritoneal cavity, and they'll loop that tubing in there. So there's some extra tubing so that child has room to grow with the far end of that shunt still being in the peritoneum, and the body will reabsorb that fluid. Signs of shunt complications, redness and tenderness along the line to the shunt, fever, headache, vomiting, neck stiffness. They may have abdominal pain. So if there's an infectious process and they have an infection in their CSF and that's draining into their abdomen, severe irritability or sleepiness in babies, swelling at their site, new loss of coordination and balance or vision changes, bulging fontanelles, sunset eyes, seizures. So congenital heart, I'm only going to cover just a little bit on heart because I feel like we got a lot of heart in last time. But congenital heart defects and disease are often detected before birth now due to imaging technology. They may or may not require surgery or may require multiple surgeries. And these kids tire out when they're feeding, active, or crying. The broad categories would be those cyanotic versus acyanotic. So you guys as EMS are going to want to know, is it cyanotic or acyanotic, right? Embryonic development of the heart. I know there might be one or two of you guys that are in pathophys, but when you look at the embryonic development of the heart, I am actually surprised things go right so much, right? 20 days, it's 2 separate tubes. Those tubes come together, they fuse, they twist, and then that heart, you end up with the 4 chambers of your heart. So your review of the heart, this is the way the blood's supposed to flow through your heart, right? We hope. Since we're talking about congenital heart disease and pediatrics, I've got the fetal circulation, which includes the placenta, and then you've got the newborn, right? In the fetal circulation, you've got fluid going to, the blood goes to the placenta. Some of it bypasses the liver because the mom is doing the job for you. Some of the blood bypasses the lungs because they're picking up oxygen from the placenta. And then once that cord is cut, you no longer have that circuit out to the placenta. More of that blood goes to the liver, more of it goes to the lungs. Etiology of congenital heart disease, fair amount of it is de novo or non-genetic, so it occurs during the development of the heart. In that case, there's nothing that the parent could have done. Some are genetic. Down syndrome, 22q, and Charge syndrome are 3 genetic disorders that include congenital heart disease. Infections during pregnancy. A reason why they want to vaccinate pregnant women, things like rubella in pregnancy can cause congenital heart disease. Specific medications, isotretinoin, lithium, ACE inhibitors, statins, and alcohol are all shown to increase the incidence of congenital heart disease. So cyanotic versus acyanotic, right? Cyanotic, significant amount of blood that is being pumped out to the body has bypassed the lungs. If unpalliated, the child will have an SpO2 below 90 at baseline. So the acyanotic, most of the blood going out to the body has been oxygenated, although some mixing might occur. So that child would have an SpO2 90 or above at baseline. So, with congenital heart disease, they may have symptoms that you would probably pretty used to assessing in adult patients, especially your geriatric patients, those right-sided and left-sided symptoms, right? So your right-sided symptoms, they have that comfortable tachypnea, tachypnea with increased work of breathing. They may have cough, wheezing, hoping we don't get to the severe cyanosis or grunting. Typically some kids with those right-sided symptoms might be a little cyanotic at baseline until they're palliated. So those left-sided symptoms have an enlarged liver, ascites, may have some edema. And typically with pediatric patients with congenital heart disease, they give them medications. So if they have, they tend to have some edema, they may give them small doses of Lasix. Multiple steps to repair, right? These kids may have surgical shunts created to increase circulation of oxygen blood. They may have surgical stents placed to keep open fetal structures to allow oxygenated blood to enter circulation. And these kids are most likely to have multiple stages. Why? Because think about the size of a newborn heart. And then when you get into transplants, there are more infants that are born with congenital heart defects than there are infant hearts to transplant. So their best bet is to rewire the plumbing so that kid gets enough oxygenated blood for circulation. So hypoplastic left heart syndrome is a common congenital heart defect. So they have that left ventricle underdeveloped. Their mitral valve is either absent or too small. Aortic valve is absent or too small. Their ascending aorta is too small. And they often have a defect or a hole between their atria. So I've got your normal heart that I showed earlier. Now I've got the hypoplastic left heart. You look where that left ventricle is supposed to be. That doesn't really help you, does it? So really, in effect, their right ventricle does all the work. So when the infant is born, the fetal shunt, ductus arteriosus, and foramen ovale, they allow that oxygen-rich blood to flow through. Those shunts typically close on their own in the first 2 weeks of life, right? Kids born with atrial septal defects have that oxygen-rich and oxygen-poor blood mixing. Goals of treatment for hypoplastic left heart is getting that low pressure path to direct that oxygen-poor blood to the lungs. And you want to decrease the work of that right ventricle because that's the only pump they've got. Because the left ventricle didn't form the way it was supposed to. So remember how I said your fetal shunts typically close? That could be a problem if you've got congenital heart disease and that hypoplastic left ventricle. They need an intervention. Norwood procedure is typically what they do. This is what they do with the Norwood. So they add that shunt. Kids will outgrow that. So then they typically get the bidirectional Glenn and the Fontan. The cardiology care team will determine when they get that surgery. 4 to 6 months of age, they get that increased demand. So the bidirectional Glenn is going to decrease some of the work of that right ventricle, right? Because you only have that little tiny shunt, and then the right ventricle is doing a ton of work. So the Glenn procedure, they're going to connect that superior vena cava directly to the pulmonary artery. And they may remove that shunt. So the Glenn procedure, blood drains back, it goes straight to the lungs, right? So the Fontan procedure, they'll have less mixing of that oxygen-poor blood with oxygen-rich blood. Typically after a Fontan procedure, that child will have an SpO2 of 90 or above at baseline without needing any supplemental oxygen. So then they connect that inferior vena cava. And then they've got that low pressure system, taking the blood straight to the lungs. And now the right ventricle just needs to take the stuff back from the lungs and take it out to the body. I'm so glad the heart educators made this look more simple, right? Because some of it looks really complicated. Tetralogy of Fallot, another congenital heart defect that you may have heard of. They've got that increased outflow in the aorta. They've got a thickened right ventricle. So their right ventricle is hypertrophic. They've got an obstruction of right ventricle outflow and a ventricular septal defect. So between the right ventricle and left ventricle, there's mixing. So Tet spell. So if these kids are unpalliated, they get that decrease in systemic resistance. They get that right to left shunt. So if they get upset when they're feeding or crying, they tend to turn blue. Some other considerations, we are doing excellent in general Not just our hospital, just everybody in general. We're getting great about repairing pediatric heart defects. But these kids grow up into adults, which is a good thing. But you guys may have a young adult that you guys will run on. Things like they may have arrhythmias such as AFib, A-flutter, VFib, have pulmonary artery stenosis, leaking heart valves. They have coronary heart disease, and they're at higher risk for a right ventricular aneurysm. So other things, temporary gut measures, things like that, like VAD devices, which I could not do a good enough lecture as Cleveland did last time. So I think they covered that topic really super well. So if somebody has a ventricular assess, you want to assess perfusion, and if their VAD isn't working, you can do manual compressions. And that's from the AHA update. Assessment, talk to the caregiver about baseline vital signs. Do your pediatric assessment triangle and check for signs of decreased cardiac output. So you're going to feel those peripheral pulses and see if they're decreased. Check their blood pressure, see if they've got hypertension, clammy skin, and mentation. Are the parents saying that the child usually talks, babbles, makes a lot of noise, is really active? They're not talking, they can't stay awake, they're not feeding well. Diapers, are they taking in? Are they not urinating enough, or are they urinating a lot more? Vomiting, diarrhea. Again, it's respiratory infection season. So, if they need those medications, or if they have that shunt dependent blood flow, vomiting, diarrhea could be a big deal real quick. Those kids with that stent dependent blood flow, just the ductus arteriosus in an infant is fairly small, right? So dehydration can occlude those stents. If they have those signs of stent occlusion or worsening cardiac output, wet sounding lungs, edema, you want to elevate their head. If you feel like they need fluids, consider instead of giving your regular 20, consider giving 10. Reason why is you can give 10 milliliters per kilo. You can evaluate the child, listen to them, make sure they don't have wet sounding lungs. And it's a lot easier to give them that second half of the bolus than be like, oops, I gave too much. Supplemental oxygen, if they're unpalliated and they're below 90 at baseline, be judicious with the oxygen, adjust the concentration slowly to get them back to what their normal range is. So, arrhythmias, find out if that's their baseline, and then intervene if there's signs of hemodynamic instability. Commonly seen arrhythmias, kids with congenital heart disease, SVT, VTAC, or they may be bradycardic. Conduction anomalies, I know this is a really busy chart. Some of that would have to do with, medications, accessory pathways, or even scar tissue. Talk about these kids having 3 different heart surgeries. That scar tissue can affect the electrical conduction, plus having a congenital heart defect where part of your heart doesn't form the way that you would expect it to. Where do those electrical pathways go? They may not go someplace that they would be expected to go with somebody who has 2 ventricles that are fully developed. Pacemakers or pacemaker defibrillators. Kids do get these devices, especially kids that may have congenital heart defects that have an arrhythmia. Your big difficulty with pediatric patients is if they don't have enough tissue, it won't be right under the skin in their chest like you're used to seeing in adults. They will take the wires, attach it to the heart, and they'll have to put the device into the abdomen. So find out if they have any, ask the caregiver, find out if they have any medical alerts, ask the parents if they have any devices. Those treatments, they may have those arrhythmias, they may need transplants as adults. So assess children with a cardiac history, assess adolescents and young adults with a cardiac history. Failure after surgery, it's a small percentage of heart transplants are pediatric patients. Ventricular assist can be used for hypoplastic left, Fontan failure, inability to oxygenate. Total artificial heart, that can be a bridge to transplant. I was looking up to see about how long. So kids spend about 145 days with a total artificial heart on average, and about 20% receive a transplant within 30 days. I have an example. This one was an older model of total artificial heart. She's got the leads and the generator in a little backpack. So other admissions with congenital heart, myocarditis, pericarditis, cardiomyopathy, chest pain, arrhythmias. So moving on to disabilities, some special considerations. Spinal cord injuries. Kids with previous spinal cord injury at T6 or higher are predisposed to autonomic dysreflexia. They have that loss of coordinated autonomic response and exaggerated sympathetic response. And these can be to pretty small things like bladder distension or bowel impaction, or more serious things like pressure sores or bone fractures. You think about somebody with a spinal cord injury, they may have decreased or no sensation below the level of injury, so they may not know that they're injured. Autonomic dysreflexia, I've got that, you've got that stimulus below the level of their injury. They send that signal, the signal gets kind of garbled, right? So problem though is that because that signal kind of doesn't go quite the right way, the brain interprets it in this way where they typically will have that, they'll try to reduce blood pressure, they might be bradycardic. They often tell you they have a really bad headache. They have a bad headache, they may be flushed, they may be sweaty, and then below the side of injury, they may be pale, they may have cool skin, they may have goosebumps. I've seen this a few times in kids with spinal cord injuries, and it's typically an infection. In kids, it could potentially be an injury as well, but typically they have a terrible headache, they don't feel well, they feel like something's not right. The worst with autonomic dysreflexia is that it could lead to a seizure and even an aneurysm. So they may go bradycardic, they may be tachycardic. So interventions for you guys, you're gonna do an assessment, obviously, right? You're gonna check them out, see if there's a stimulus, look at if they have an intervention like a catheter, check for signs of infection. Remove any kind of stimuli if possible. If they've got on belts, tight-fitting clothing, you're going to loosen their clothing. And if they're hypertensive, you're going to administer antihypertensives per protocol. Complications, they could go into hypertensive crisis, they could go really bradycardic, have cardiac arrest, seizures, or intracranial hemorrhage. And the intracranial hemorrhage would be a result of the hypertension. So moving on with movement disorders, cerebral palsy. There are 4 different types. So you've got spastic, dyskinetic, ataxic, and mixed. So mixed could be some combination of the other 3. So they may be stiffness, They may have uncontrollable movements. They may have difficulty with balance and coordination. So cerebral palsy will affects the brain and how it sends messages to the muscles that control body movement. Considerations for you guys, they may take medications such as baclofen to relax stiff muscles. They may have an implanted pump. If a child is ill and can't take their medications, their involuntary movements may be worse. They may have adaptive splints or mobility aids to help them. So make sure that you either keep the equipment on them and with them, or you have the caregiver take the equipment because it may be custom, so it may be difficult to replace. They may have stiff or contracted extremities. So you want to ask like, hey, can they move this? Can they not? If not, you don't want to try to extend that. Here's an example of your baclofen pump. This can help people have that control long-term of their muscle spasms. This little device is implanted under the skin and the catheter goes into their spine, and the well is filled by their doctor. They're able to inject and fill that well. The considerations with genetic disorders, they may have less effect on it, may have more. Down syndrome, another common genetic disorder. So it's on a spectrum. They have varying degrees of intellectual disabilities, and 50% have a cardiac defect. So find out if they have a history of cardiac surgery. Where it can be relevant if you're responding to a fall or a motor vehicle crash is that about 15% of children with Down syndrome have increased mobility of the ligaments between C1 and C2. So they have an increased risk of subluxation and spinal cord injury. Brittle bone disease, another one. Osteogenesis imperfecta occurs on a spectrum. They may have curved spine. They get fractures very easily due to a lack of protein collagen, and they may have implanted rods in their extremities. They'll receive fractures from minor trauma, including falls from standing. Find out if they've had orthopedic procedures or rods or artificial joints. Muscular dystrophy. There are over 30 types of muscular dystrophy. I know Duchenne is one that gets a lot of press, which mainly affects males, but all the other types affect males and females equally. Considerations for EMS. Not so much with you guys, right? You guys probably aren't giving any inhaled anesthesia. Succinylcholine for intubation, I suggest avoiding children with muscular dystrophy because they tend to have the worst side effects. Considerations as well is that patients with muscular dystrophy often are steroid dependent because the steroids help control their muscular dystrophy symptoms and help preserve function and movement. So they don't have their steroids due to vomiting or diarrhea. They can't keep that in them. They can have signs of adrenal crisis. Also with muscular dystrophy, they may have brittle bones from that long-term steroid treatment. And so they have a higher risk of fracture, especially long bone fracture, and a higher risk of fat embolism syndrome from long bone fracture because they've got those brittle bones. Interventions, guys, blood pressure, check their sugar, fluids if needed, steroids if they're unable to take their steroids, if it's in your protocol, and respiratory support or oxygen. Talking about adrenal crisis, right? What's adrenal crisis, right? Where are the adrenals? They sit on top of the kidneys. They're controlled by the hypothalamus of the brain. Adrenal, besides producing adrenaline, right? They produce cortisol and aldosterone. Cortisol helps your body respond to stress, controls your blood pressure, your glucose, and your metabolic rate. Aldosterone gives messages to the kidneys to balance sodium, potassium, and water. So too much cortisol causes Cushing syndrome. That can be caused by tumors, medications. Sometimes people with Cushing's kind of have a little bit of a pot belly. They might look like they have a lot of stretch marks. They have high blood pressure, puffy face. So patients with Cushing's, find out medications. Do they take steroid-containing medications, or do they take medications to suppress cortisol, like midtane? Look for signs of illness or injury and give them some symptom-based management. Transport them on, right? Adrenal insufficiency. So the adrenal glands do not produce sufficient cortisol and or aldosterone. Maybe one, maybe both. So people with adrenal insufficiency need daily supplementation of medications designed to mimic cortisol and or aldosterone. Hydrocortisone, prednisone, and fludrocortisone are examples of these medications. So if they take medications like steroids long-term for other health conditions and abruptly stop, so somebody on long-term steroids, even if their adrenals worked before, but now they've been on it for things like muscular dystrophy, if they suddenly stop, they can have adrenal crisis. So that could be your muscular dystrophy people, that could be your asthmatics. Adrenal crisis can be life-threatening. Considerations, fluids and steroid replacement. Adrenal crisis, abdominal pain, confusion, level of consciousness changes, dizziness, lightheadedness, fatigue, headache, low blood pressure, nausea, vomiting, fast heart rate, fast breathing, and they may be real sweaty. So, adrenal crisis, some families, just like they have the seizure action plans, kids that are steroid dependent will have an adrenal crisis kit. They will get a dose of Solu-Cortef in a kit, and if they're unable to take their daily steroids, they are supposed to give that kit. So they'll have that for an emergency. Think of that as their EpiPen to prevent them from going into adrenal crisis. And if they have it, it's okay to ask, hey, have you given them their emergency steroids? So, long-term vascular access, more things with special healthcare needs, right? PIC versus a peripheral IV. Peripheral IV, right? Really small, maybe 3/4 to 2-inch long. PIC or central venous catheter can be as long as 60 centimeters. The size depends on the size of the patient. Fundamentals from the EMS standpoint, most agencies don't give medications or anything via PIC line, but you want to take a look and assess the site and make sure it's not part of the problem, right? Ideally, that should be drawing, flushing. PIC line should match documentation of placement. So in that case, you have this PIC line, it looks good. If that line is pulled out way past where it's supposed to be, we're going to say, hey, that's probably dislodged and not push it back in, right? But we're going to make note of that. Like, hey, they have a PIC line. The card says that it's supposed to be in, but now it's there's a big bunch of it pulled out. Or, is there signs and symptoms of infection? So hemodialysis access, check that site too, right? Arteriovenous grafts, check for that bruit and thrill. Your fistula, so that's how it works. They've got that fistula where it goes to their dialysis machine. So the bruit and thrill with their normal functioning fistula, you're going to listen with your stethoscope. You're going to hear an audible sound from that turbulent blood flow, and that's your bruit. And then you're going to put your fingers really lightly over that fistula site, and you're going to feel that turbulent blood flow. So if you don't have both of those things, I would make a note of that in the chart and pass it on to your ER when you give a report. Tunneled venous catheters, sticks out. They tend to be tunneled all the way almost to the heart. They tend to have the end out the chest. Other central venous catheters, maybe called Groshong, Hickman, Broviac, or Leonard's. Looks a lot like a PICC line, except goes from the chest and all the way right there to the main of the heart. Ports, power port, metaport, infusiport, or portacath. The access point for that central venous catheter is under the skin. It's accessed with a special device, a port access, power lock, or a Huber. This is what it would look like if it was unaccessed. Sometimes they'll be accessed if they are getting active chemotherapy or fluids or other things. They may leave that needle in with a dressing over it for a couple days. The portacath under the skin, and there's where it goes. There's how it gets drawn into that well. So considerations typically need to be flushed. You don't want to put telemetry leads on the report. It can become dislodged. So trauma, manipulation, or patient growth spurt. So some people can do what they would call port twiddling, which means they can manipulate the port. And once they realize it moves, they can actually flip the port. And then you want to look at the skin for signs and symptoms of infection. Moving on a little bit more to behavioral. We got autism spectrum disorder, first recognized in the 40s. Autism and Asperger's were once considered separate disorders, but now they're part of that autism spectrum disorder. CDC estimates about 1 in 59 kids in the United States have autism spectrum disorder, with the average age of diagnosis being 4. Spectrum disorder because it varies on that type and severity of symptoms. They may attend special therapies to help them communicate better and function well in school. So everybody's different. So IQ, they may be gifted, they may have some developmental or cognitive delays. Social interactions, they may be aloof, they may be passive, they may be really active and interested in talking to people, nonverbal to verbal, coordinated, not coordinated, sensory. You could drop a book by their head and they don't flinch, or you could have one that noise bothers them. So they may have difficulty when communicating when overstimulated. So multiple people, EMS, fire, everybody. Going back to your team dynamics, somebody has autism, designate one person to talk to the patient so they're less overwhelmed. Short, direct sentences and tell them what you're going to do before you touch them. Some of them may be really sensitive. Communication, sign language, communication boards, to help them communicate, do the best you can, explain care. Communication devices and tablets are more common. It's another one of those devices that have become much more cost effective, and they can be super useful for people with speech delays or autism. If you can, keep the device with them to help them communicate. With autism, assistance might be challenging. They may want to go tight or hide themselves if they're overstimulated. I had an example. We had an autistic patient that was an adolescent, but when the house was on fire, they went and hid. So it took a while to find them. They may try to return after accident. They may feel, self-inflicted accidental injury. So maybe they're biting themselves or doing repetitive motions that might injure themselves. And they may have a lack of understanding of danger. So at the scene, if you're on a roadside scene or someplace, besides scene safety, make sure that you have patient safety. So this may be one that if they're on the side of the road, you want to try to get them into the truck as fast as possible because they may not understand that there's still traffic around and that they need to stay put. Quick repair strategies, open up that opening palm, drop arms, try to look non-defensive, back up, be quiet, calm voice. I know EMS, you're time bounded. It may take you a few more minutes.
threats, consequences, things like that don't help in the situation. So I'm going to say use direct communication. Calm kits, comfort objects can be really helpful, not just for autistic kids, but kids with developmental delays. So sensory kit, calm down kits. Seen there's several agencies, I believe it's Detroit, that just deployed a bunch of calm kits for their pediatric patients where they put a few little things in a bag to help kids with that sensory distraction. Family and caregivers, kids that have difficulty communicate may not verbalize pain. So look for nonverbal signs and symptoms and move slowly. Had a run that was a motor vehicle crash. The child was actually standing next to the car when EMS arrived. Seemed a little agitated, didn't have any bleeding, wasn't complaining of pain. They had a tib-fib fracture that they were standing on. That was discovered because they did a really close assessment and started doing a full trauma workup on the child because they weren't having trouble communicating with them. Consideration for transport, kids with special healthcare needs, you know, do they have communication barriers either through that or even through language barriers? Primary caregivers, explaining care, bringing the go bag, home chart or emergency information form if they have it. Special restraints or splints or orthopedic devices. You know, decide real quick if you're going to keep them on or if you're going to leave them with the caregiver, and then secure all home healthcare equipment. A little bit on behavioral health. I know we're into the final stretch, right? Behavioral health has gotten a little bit more attention lately. I think it's a little bit harder. We've kind of had the whole COVID times for a while now. I think it affects everybody. It definitely affects adolescents. They're growing, they're developing. About 1 in 6 youth between the ages of 6 and 17 experience a mental health disorder every year. And half of lifetime mental illness begins by age 14. And suicide is the second leading cause of death amongst persons 10 to 34. So that's why it's important. Risk factors, ACEs or adverse childhood experiences. If you guys are familiar with this term. So adverse child experiences, there's a quiz. So I know this quiz is kind of small to see, but I put the link in if you guys want to look at what the adverse childhood experience questionnaire, what that score. So people with an ACE score of 6 or higher are at risk of their lifespan being shortened by 20 years. 20. That's pretty significant, right? 1/3 of mental disorders worldwide are attributed to ACE. Anxiety, depression, PTSD, substance use disorder, and aggression are common to children with high exposure to adverse childhood experience or ACEs. And those issues frequently persist into adulthood. ACEs and you guys. This is where you don't assume everything and you know yourself first, right? ACEs increase the risk of chronic disease, mental illness, violence, and becoming a victim of violence. ACEs affect our careers as adults. There is a higher rate of workplace absenteeism in adults with ACE scores over 4. So as adults and first responders, you can't change your personal ACEs because they occurred in childhood, right? But what can you do as an adult? You can address your own physical and mental health. That maybe you had some adverse childhood experiences that weren't so great. How is that affecting you now? And how can you prevent your children from family members from having ACEs? So, trauma-informed care, another word that makes it sound complicated, but you know what? Knowing what your ACEs are and how they affect your patients and yourselves can help you provide trauma-informed care. You only spend a short time with these patients, but you are the first contact with the medical system. And sometimes you guys are the main contact and you're the only contact. Them knowing that EMS are going to be there and treat them with respect, that matters. EMS and trauma-informed care, things that you guys are probably already doing, right? Cultural, historical, and gender issues. Understand if you don't understand what somebody's culture is, ask. Safety, trustworthiness, and transparency. Those are core values of EMS, right? I mean, you want your patients to trust you. You don't want to lie to your patients. And you want everybody to be safe. You know, the patient and the family are trusting you to do their job correctly. So your interactions with each other as a team and with the patient show them that you are transparent, honest, and that you're going to do what you say you're going to do. Peer support, collaboration, and mutuality. You know, peers are individuals who have lived experience of trauma. You know, for children, this may be family members or caregivers. Collaboration, mutuality recognizes that meaningful sharing of experiences, that, you know, roles, power, and decision making are valued at the team at every level of the team. So more on mental health disorders in kids. So depression is the fourth leading cause of illness and disability amongst adolescents 15 to 19. And behavioral disorders are the second leading cause of disease in adolescents 10 to 14. Eating disorders commonly emerge amongst adolescents. That can be anorexia, bulimia, binge eating. So empowerment, voice, and choice. That one got out of order. That was supposed to be before this one, right? Recognizing the abilities of individuals, organizations, and communities to heal and promote recovery. You guys can use your own knowledge as survivors to provide better care for those experiencing trauma. So talking more about adolescents and their families. So inclusive language. Adolescents may have caregivers and those that they consider family that are not their biological parents. So foster care, examples, kinship, step parents, members of the LGBTQ community may have people that they consider their family. Those connections are important for them to have. So find out, you know, who do you trust? Who is your caregiver? Who takes care of you every day? Where do you feel like you belong? You know, some of these kids and adolescents may not even live with their biological parents. So, you know, more on adolescence, you know, names and pronouns matter for all kids, not just adolescents. If they have a preferred name or nickname, mutual respect. But I had some review, and this was a study of transgender and non-binary children. They found out that if these children feel supported, then they have better psychological functioning. So call them what they ask you to call them. It's important. More on adolescence, so risky behavior and suicidal ideation. Self-injury may include scratching, cutting, burning, branding, biting, hair pulling, or skin picking, home piercing or tattooing. That's a poke and stick, kind of like more of a street term of that. Multiple reasons for self-injury. You know, some of them have difficulty regulating emotions, so they may self-injure to release their emotions. They may do that self-injury to take risks, rebel, or state their individuality. You know, things like home tattooing or branding. It may also be a symptom of autism, developmental delay, depression, PTSD, bipolar, suicidal ideation, or abuse. So suicide in adolescence. You know, warning signs, they have changes in thoughts, behavior, feelings, preoccupation with death, indirect or direct suicidal statements, notes, and plans. It's okay as EMS to ask somebody if they're feeling like harming themselves. I think it's important because they may, a lot of times adolescents, they may hide stuff from their parents, but if you talk to them without their caregiver or parent, they may be like, yeah, I did feel like hurting myself. Remain calm, provide that active listening, try not to make statements that are judgment or accusatory. It doesn't help to scold them or try to make them feel bad. Stay with the adolescent, get them transported, seek assistance or help for the child, and remove any means for self-harm. Substance use disorder. Persons from 12 to 20 consume 1/10 of all alcohol consumed in the United States. 12 to 20. What's the drinking age? Right? Half of 9th to 12th graders have used marijuana, and 2 in 10 12th graders have reported using a prescription medication that they do not have a prescription for. So, some other considerations with adolescents. Talk about adolescents and youth that are non-conforming or even transitioning. Ask them about hormones, hormone blocking medications. Ask them if they have compression garments, if you need to place leads, right? They may actually, kids, both LGBTQ or kids with body image disorders may wear multiple layers of clothing or compression garments to make them feel more comfortable in their body. So, ask them if they can move it, ask them if you can put a lead underneath it, and help them if possible. If it's a trauma and you have to cut off their clothes, I get it. But otherwise, you could ask them to help, like, hey, can we loosen this? Could we take this off to do my assessment? And then help them if needed. Considerations. And I really was trying to make the most of this behavioral disorder part into focusing on where places that I could integrate EMS, because I could go into the pathophysiology of schizophrenia and a whole bunch of mental health disorders, but it doesn't really help on how you're going to take care of and transport the patient. And I get a lot of questions because, pediatric patients can make people uncomfortable anyway, but pediatric patients with behavioral health crisis, sometimes you just don't know what to do. And sometimes you have to think about what are your communication strategies, right? LEAP is one. I know this one is also in mental health first aid, if you guys have taken that course. Do you have listen, show the patient you're listening to so you could reflect, acknowledge, empathize and acknowledge that their feelings are real. You may go out for a child with mental health crisis and they're fighting with their parents. They may have called their parents some choice words. And that probably seems kind of disrespectful, right? But if they're having a crisis, tell them they're pretty disrespectful. I think they may already know that, but really it's saying, hey, I understand you have a lot of strong feelings today, and make observations together. You yelled at your parents and broke a bunch of stuff, and now how did that work out for you? And find a shared goal. Some of the shared goal can be, hey, we're gonna have you just sit tight in this seat with your seatbelt buckled until we get to the hospital. That can be a shared goal, right? Conflict coping. Acknowledge that everyone gets angry. Discuss their feelings with them. Remember, they're still children. They're emotionally immature. Their brains are not done developing. So you can tell them, like, hey, I know when I get mad, my heart rate gets high. I might feel sweaty, might feel difficult to concentrate. I might feel like you need to do something, but what I need you to do is take some breaths, I need you to count with me. I need you to talk to me longer. Do what you can to do that, do that conflict coping, do some of that de-escalation. Acknowledge, calm down. Things like distraction, music, like, hey, can you play me your favorite song? Think and talk, tell them like, I know you feel like you want to run, but how about we sit and talk about some things that are helpful. Avoid name calling, returning insults. They may call you choice words, right? But listen, what do they really want? And it's okay if you need to keep some distance at the beginning. So another consideration for you guys is that somebody in that acute mental health crisis might not be able to see that they are ill. That may also be why they're non-compliant if they have a diagnosed disorder with medication. They'd be like, oh, well, I feel better, so I stopped taking my medication. Now you're getting in fights at school, you've injured yourself, but I felt better. They don't understand that they felt better because they were on the medication. So also, assessment, rule out emergencies or trauma. Check glucose, look for signs of trauma, signs of injury. Somebody with a traumatic brain injury may start acting erratic or saying things or be really irritable. Ingestion and intoxication, went back to the alcohol, illicit drugs, and use and misuse of prescription drugs. You could have somebody that appears to be having a mental health crisis and they've ingested something that was not theirs, or overdosed on over-the-counter medications. Even things like Benadryl. Somebody overdoses, takes a little too much of that, they might start acting erratic, say stuff that's not making sense. You might think they're intoxicated. So risk assessment with ingestion, since we're talking about behavioral health, find out what did they have, if there's any medications at home. The family said, hey, I found this half a bottle of pills, bring it with you. Who are you going to call on that? Poison control, right? Poison control, or your medical control, or both, right? Poison control can help if there's any specific considerations, if somebody ingested either over-the-counter or prescription med, or even a household cleaner, and somebody, decide out of self-harm they want to drink bleach. Hyperthermia ingestions, think about things like alcohol, cocaine, amphetamine, and derivatives. That would include your ADHD medications. Dose of diuretics, laxatives, atypical antipsychotics. Toxicology, thinking your A, B, C, and D, right? Airway, breathing, circulation, and decontamination, if they've got anything stuck to them, right? And then sugar, seizure control, and supportive care. Poison center, I say Columbus or Cincinnati, call them. Considerations with glucose. DKA. Sorry, I know I'm starting to run thin on time. So DKA, another thing that the reason why I stuck DKA all the way back here is that it can be super common for adolescents to present in DKA. Either it's their new onset diabetes, or through infection or failure to take prescribed medication. Also, if they're under extreme emotional distress. They may have difficulty concentrating or altered level of consciousness. They may even be slightly combative, and they tend to have cerebral edema. The increased mortality risk in teenagers, they have those psychosocial factors, so medication non-compliance, and they may feel some stigma about diabetes or weight. Diabulimia is kind of not really a medical term, but it's kind of a buzzword where somebody who is diabetic, they may have an eating disorder where they feel that if they take their medications as prescribed, that it makes them gain too much weight. So they will withhold medication and or food and not eat as they're supposed to, and check their sugar and take their insulin. They'll withhold those doses. Delirium with agitated behavior. So Bell's mania or acute exhaustive mania from the 1850s was described. And the 1980s is when excited delirium came out as a buzzword. It was often associated with psychosis that was linked to cocaine intoxication. People present with bizarre and aggressive behavior, shouting, paranoia, panic, and hyperthermia. So delirium, even in pediatrics, about 29% of critically ill children will have delirious behavior. They may be agitated and aggressive or bizarre. Delirium with agitated behavior complications are hypothermia, full autonomic collapse, injury, or sudden death. Autopsies of people with delirium with agitated behavior that had sudden death often show a dysregulated dopamine transporter function in the brain. And some other studies show positional asphyxia due to restraint as a cause of death. Considerations for EMS and restraints. De-escalation is your first line, right? You want to use your therapeutic communication, do that shared goal, distraction. And then law enforcement restraints. So for patients in restraints placed by law enforcement, consider changing to an EMS restraint when possible. If you need to, bring a law enforcement with you if they're in law enforcement custody, but change from a law enforcement restraint to a medical restraint. So considerations, start off with your de-escalation or LEAP, ensure your safety and the patient's safety. Follow your protocols for sedating medication administration and or restraint use. Assess and reassess the patient frequently for changes in level of consciousness and vital signs. So back to, one of my examples for that with a law enforcement restraint, I've got this patient that's prone. You don't want to transport somebody prone. It's going to be difficult to do an assessment. It can be more difficult for them to breathe. Final thoughts. Since I talked about all this behavioral health and autism and suicidality and your ACEs, right? Erasing stigma of mental health. Talk openly, educate yourself and others, be conscious of language when talking to children and families, encourage equality in treating mental illness like it's a physical illness, and show compassion, be honest, speak out, and then choose empowerment over shame. It's okay that some people have mental illness. It's okay to talk about it. So arriving to the emergency department, back to your team dynamics, right? What is your role in advocating for a pediatric patient? You might show up with just the kid, right? Maybe mom and dad have to drop one sibling off at the babysitter and they have to grab the car seat. So you need to advocate for your patient. NIST is our mnemonic we use in Central Ohio to standardize handoff procedures. Really make sure you're giving that good report and it's organized. Representation and reducing stigma. Representation matters. I think it's important. I said we started off with special needs, moved on to some behavioral. Show that these people are in our community, they belong in our community. So I have my examples today. I've got Kate Grant from Benefit Cosmetics. I did not know until I was updating this talk that Lil Wayne had epilepsy. Peter Dinklage with achondroplasia, if you guys are Game of Thrones fans, and Jamie Brewer has Down syndrome. You may recognize her from American Horror Story. Bethany Hamilton, professional surfer, amputee. Ed Helms, I did not know that he was born with aortic and pulmonic stenosis, so he had congenital heart disease. Dennis Rodman has asthma, and Marley Maitland, hearing impaired. That's funny. So when I took over this talk, special needs is a topic we teach pretty often at outreach with community EMS. Welcome to Holland. I don't know if anybody's familiar with Welcome to Holland. So Emily Pearl Kingsley, the writer for Sesame Street, her son was born with Down syndrome and he appeared on Sesame Street as a child. So that's above. She wrote Welcome to Holland about how raising a child with disability is a different journey. But Jason went on, he was in Sesame Street. He went on to author his own book about growing up with Down syndrome and how his life was. More on reducing stigma, talked about mental health. Carrie Fisher, of course, she's now passed on. She had bipolar disorder and substance use disorder. Dwayne "The Rock" Johnson has depression. Doesn't seem like somebody that I would have guessed that had depression, but like I said, you don't know with mental illness, you don't know what people are going through. Mariah Carey had bipolar disorder, and Elton John has struggled with bulimia. My summary, kids with complex medical needs should ideally, be transported, get them to their medical home, get them connected with their specialists, enlist the help of family members and caregivers to assist in providing that information and history, and then utilize tips, things like tips for first responders, use your EIF, use your therapeutic communication and your de-escalation tools to help you, not only guide your assessment, but to, help, improve communication. Final thoughts. So like I said, what is your role in advocating? How do you communicate your assessment? And what are some best practices for mental health, not only for your patients, but for your workplace so you can take better care of your patients? So that advocate for your patients. That's our MIST mnemonic. I don't know if you guys, I don't know what mnemonic you guys use up there in Youngstown, but there's not one perfect one. I think it's just important to have an organized EMS timeout or handoff, and that the hospitals owe you that timeout. And I will advocate for EMS on this every time. If you did these interventions, if there's something they owe you that report. There's no point for an asthmatic. Once you've given 3 duonebs, is there a point for the ER to give the 4th duoneb? Not really, right? The albuterol is going to help them, but does Atropine really help them after 3 doses? Not really. But if they've taken 3 duonebs, maybe they need some more aggressive measures, right? So, the ER doesn't need to reinvent the wheel because they don't need to repeat stuff you already did. So. Hey, somebody's happy. So I've got a few references, and that is it. I'm going to minimize that screen. And then I think, there we go. All right, I'm moving it back so I can see any questions. So questions, concerns, or pleas for insanity? You guys can't go quiet on me now.
Hey, Laura, this is Larry. So I just, you're a trooper for powering straight through. Just want to say that. That's 2 long hours, and thank you for your knowledge and sharing everything. So just to kind of give you an idea of what we're doing here in the local area, what we've done is we've kind of taken the size of the pediatrics, and for seizures, if you can actually pick up a kid with one hand, then we're going through and we're just saying, based on the average size of that patient, go ahead and give 2.5 milligrams of Versed. If it takes you 2 arms or 2 hands to pick up a child, then go ahead and get 5 milligrams of Versed. And then if there's signs of puberty, we're going to give the adult dose. So we've kind of like done it down and dirty to try to get rid of all the math. So that's something that we've done here. Maybe you can share with some of your EMS agencies over in Columbus.
Actually, not Dr. Bubbles, our direct medical director, but Dr. Julie Leonard, who does some EMS research. She actually got a few departments recruited for their PD dose study, which is kind of similar. Let me see if I can, I know I've got the flyer that I just posted up. Hold on. Let me see if I can flop this over. But where is it? There we go. The PD dose, I think they made it into, I believe there's only 3 categories. But yeah, Texas Children's is doing it, and there's the study website, if you can see the end of my flyer.
Okay, yeah, I'll scan that and
For that,
check it out.
yeah, for that PD dose study, it's something that's kind of, I joke, I kind of said it was a more simplified hand heavy because it's more like yours where there's less categories.
And it seems to work well with us by doing that thing. So again, for those who might not be familiar with it, is if you have a kid and you can pick that kid up with 1 arm and they're seizing, or you think you can pick that kid up with 1 arm, go ahead and give 2.5 milligrams of Versed. If that kid is larger and you need 2 hands to pick that kid up, 5 milligrams of Versed, and then of course, larger than that or signs of puberty, we're going with the adult dose, which for us is 10 milligrams based on the Rampart study. So it does work, and we haven't had really any problems or complications with giving those set of guidelines. The other thing we're doing out here is ketamine for kids, either intranasally or actually nebulized ketamine for pains, and that works great. And we're doing like a dose of 0.1 to 0.3 mg per kg, and that's working out well for pediatric pain medication. And that's great. And I'm not sure if any agencies in Columbus that you're aware of are doing that either. But
I know they give ketamine, but I don't think we've been nebulizing it. I think they.
Yeah. Okay. Yeah, nebulization works pretty well. We don't really. So we just drop the amount of ketamine straight up, and then the dose that they need, and we mix it with saline to achieve like the either 5 mLs or 3 mLs total solution. So and we just put it up to a mask nebulizer, and we do kind of blow by, and that works.
Oh, that sounds like.
And we're purposely trying to put them into a little bit of a hallucinogenic states with going a little bit larger than what they need, because it's okay if a kid, starts to have a vivid imagination because they're probably going to see purple elephants, and butterflies. But whereas for an adult, if we put them in a hallucinogenic state, they might see their worst fear, like spiders or snakes come out of the back of the ambulance. But both the intranasal and the ketamine is working, the nebulized ketamine is working really well in pediatric pain termination. And for us. But one of the big things is you do have that unruly child, right, for whatever reason, and your de-escalation techniques have failed. A lot of providers are skeptical to sedate a child. With the ketamine, we can give a little bit more, and kind of calm them. But what's your experience with your hospital and the perception of coming into the ER with a kid that probably needs sedated, and the reassurance to EMS that, you might need to do that to bring them in for everybody's safety?
And I actually had several discussions when we opened our crisis. We had, before we were, our pediatric mental health crises were going into a section of the ER, right? Which a lot of hospitals do. They actually opened up in the psychiatric hospital a crisis unit. So if it's only behavioral, and I feel like there was a fair amount of disconnect between EMS and like our inpatient providers in the beginning, because they, in the case of us in pediatric behavioral health, their first line is maybe to take away stimuli, things like that. And then they were kind of concerned about medication and, giving sedating medications because that wasn't something that they typically did inpatient. But, we had to talk a lot about, one, the state protocol kind of not being, not really wanting EMS to, put patients in restraints too often, which is to me is valid because I worked community ER before and I had people that were not medicated very much and they're locked to the EMS cot, but pretty much once they can barely get the cot through the door because the patient's trying to rock the cot. And so we kind of had a few discussions and involved EMS, especially because we had a few people that, unfortunately, were frequent utilizers of service that needed to be medicated. And, things like ketamine, the benefit would be that it's not going to, completely depress their respiratory drive. But, really our providers had to think about some of the unique challenges for EMS and why why medication may be needed that they might necessarily not do in an inpatient or an ER setting. So they've gotten a lot more like, oh, okay, let's talk to them about their protocols. Oh, I get that idea, more because we had to discuss some of the differences in practice and, the fact that you have to keep somebody from jumping out of the back of a moving vehicle on the freeway. So ketamine is one that we typically see. I see ketamine the most often. Occasionally, I will see some Versed given by EMS agencies, and it's basically whatever it takes to get them, safely transported. And then if somebody is sedated, they may or extremely sedated from the medication, and may need supplemental oxygen or bag valve mask, they may have to bring them to the main ER for observation and medical clearance. But
I think the ketamine and Versed work a little bit faster than a lot of providers have asked about Benadryl. Benadryl has a little bit longer onset time. So do you have any experience in the ER with using Benadryl on a kid versus the other agents?
They tend to, in the ER, they tend to use, if it's the ER, they tend to use ketamine. If it's the psychiatric crisis, they have more specific protocols, but that's because they're in the psychiatric crisis. So their stuff's a little different. But they tend to just give them that ketamine because it doesn't depress their respirations and it wears off. It doesn't have that super long duration. And so they give it if they have to give it. And then, when they're stable, they turn them over to the inpatient psychiatric people that have their own protocols and different medications. So
awesome. Well, thank you very much.
It's definitely been a learning curve, even for us to have our own. Like I said, I've not worked in the psychiatric ER that we have, but the fact that we have like a kind of, like I said, our psychiatric, we call it the emergency department for behavioral crisis, without injury or ingestion, but they're able to take care of a lot, but they also have more specific professionals to kind of start some of those therapeutics that are going to provide more long-term stabilization. So it's useful. But like I said, I think just as a state, I think we're underserved as far as mental health, which can be kind of unfortunate, especially like I said, with COVID and people being locked down and socially distanced. So I don't know what your situation is up in Youngstown, but I'm sure it's the same as the rest of the state. That sometimes you're kind of struggling to get enough behavioral health facilities for the people that need it.
Yeah, I think that's true for all hospital resources, whether it's behavioral health and rooms and ICUs. COVID's really put a dent in the healthcare system.
We're on. I was making a comment while I was in the office today about how many times we've been in our EPTP because we have our transport plan where they try to spread the love. what they can. I don't know, or EPTPs are fancy initials for our diversion plan. So
Okay.
that where they try to even incorporate some of the freestandings to spread out the patients when the ERs are at full capacity. And
Yeah, I know we're working on alternative destinations protocols, whether it's freestanding or like maybe mental health, or maybe now it's evolving to EMS treat release with a QR code to follow up with a physician or get that
yeah,
and with EMS in order to guide treatment. So that's all in development now with the COVID surge. And, we'll see where this takes us, maybe for better or worse, but, things are happening.
right. And on the flip side, we're deployed out from the pediatric standpoint. We've been giving everybody's kids like our school-based healthcare. We've recruited nurses to pick up extra shifts, and we're going to all the schools and around Columbus and vaccinating kids, plus having clinics on site to vaccinate kids and adults. That's one of the things that I've picked up on top of my regular duties. Now and again, I've picked up some vaccination clinics. I started off with staff, moved on to clinics that were sponsored by the Board of DD, so people with developmental disabilities and physical disabilities, and then adults, and then little kids, and kids as young as 5 now. They're bringing down that age, and it's been a lot. But hopefully we'll be able to push through that this year, because our respiratory season, while we don't have the diversion issues, it's still getting a little tight for us, because things like, you have infants, diabetics, I've been talking special needs, kids with bronchopulmonary dysplasia or other chronic lung issues. If they get COVID, it could be disastrous, because they already have pre-existing health issues. So that's a rough one, but I appreciate you guys having me on, and hopefully I helped everybody learn a little bit more about taking care of kids with special healthcare needs. I know it's, I said pediatric calls are a smaller portion of your practice, but it's more likely to be somebody with chronic medical needs. And unfortunately, it seems like more EMS transports, have to do with mental health crisis. So I hope giving people some extra tools in the toolbox can help make it an easier time, just to figure out, what am I going to do if I have to transport these types of patients. So
No.
at any rate.
No, we really appreciate you coming and sharing with us. We like, that's one of the things we're trying to do here, is get a different perspective from other places and what are other people doing. And I think it's been great over the last couple of weeks. I appreciate you participating. This isn't going to be the last time we do this or something like this. So I'd love to be able to keep you on the list as a resource if we need you.
Absolutely. Like I said, we do send some kids up your way now and again. So I know I did one for Youngstown, I think 2 years ago. And then we had a few that were co-managed with Pittsburgh. So out of some of our special, some of our special needs clinics, especially congenital heart and some of the genetic disorders. So it's something that I feel like everybody's going to get more of that as we kind of, as the research advances and they find some of these genetic causes for, everything from behavioral to epilepsy. So I expect we have more words for things as we figure out how things happen and how to treat things better. So again, thank you guys so much. And I hope to be on again, okay?
Oh, you're very welcome. Thank you. And feel free to stick around if you want.
Well, all right. Thanks.
Okay.
Uh-huh.
Thanks so much, Laura. Have a good night. All right, everybody else, I'll give you a couple-minute break, but I'd like to get started right back up. But just give me time to set everything up here. Actually, see, I have a couple hands up. Are those hands up just for Oh, those must all just be for attendance. All right, awesome. You guys are step ahead. So take a quick break and I'll be right back with you. All right, everybody, in the interest of time, let's get started again. The topic I'm going to be talking about tonight is the rise of infectious disease. And obviously, we're living through a historical time with the pandemic, but we're not going to focus completely on COVID-19. This is there's more to it than that. So my disclaimer tonight is I realize in the last few years, the U.S. has been crazy with vaccine controversy. There's anti-vaxxers, pro-vaxxers, all this stuff. I'm really not here to argue that point one way or the other. There will, of course, be vaccines and things like that mentioned in this talk, but I'm not trying to be political, controversial, or anything else, or try to talk you into or out of anything you want to do. That said, we do have to take a look at the anti-vaccination movement. Primarily in the United States around in the 2010s, we had a surge of anti-vaccination people for whatever reason. I mean, and everybody thinks they're doing the right thing, I think. So for whatever reason, people decided that vaccines were no good. We had a surge of that in the US in the 2010s. But it's not a unique situation. We can look back in time, and I'm not talking about, we're not going to look back to the 1700s or anything. We're just going to look back a little ways at what has happened with anti-vaccination movements and the results of those things. Again, these aren't opinions. These are just facts and numbers. So in 1974 in Japan, 80% of the kids were vaccinated against pertussis. They had 303 pertussis cases that year. But the vaccine, there was a rumor about the vaccine that it was possibly harmful and could cause some birth defects and things. And so that fell off. And in 2 years, they went from 80% to 10% of infants vaccinated. 3 years after that, they had 13,000 pertussis cases in Japan. Since then, and 2 years later, after they realized that, they revised their vaccination program, did a little better job of the public relations with it, and they're down to 400 to 700 cases per year. Great Britain in 1974, same era, 81% vaccination rate, 2,069 confirmed cases. Same rumors spread in Great Britain. The vaccination rates declined to 30% of infants in 3 years. So a year after that, they had 100,000 pertussis cases. 71% of the deaths during this outbreak were infants. 1981, 1982, acceptance rose slightly to 45%, and there's still over 50,000 cases a year. So they went from 2,000 cases to 50,000 cases. Excuse me. Sweden in 1981, vaccine efficacy in question, 700 pertussis cases per 100,000 children in that year. By 1985, pertussis increased to 3,200 per 100,000. That's a huge, huge, huge increase, almost fivefold. In the Soviet Union, vaccine safeties were questioned. Vaccine rate began to decline over the next few years, and they had 839 diphtheria cases in 1989. By 1994, they had 50,000 cases and 1,700 deaths. So why do I have a question mark there? Well, I think history is going to judge us. History is going to judge what happened in the United States and around the world in this pandemic. And we're going to see. We're going to take a look at that data 5 years from now, 10 years from now, and we'll see what happened. Again, not trying to cause any controversy, but with the vaccination program in the United States right now and the turmoil that it's in, it's going to be interesting in the future to see what effect that had on the United States. Per the World Health Organization, proper hygiene has contributed to the decrease in disease rates, which is probably true. However, disease outbreaks in the 70s, 80s, and 90s, eras that have similar hygiene as today, have occurred in response to decreasing vaccination. So in other words, this isn't because we have better hygiene or worse hygiene or anything else. The common denominator here is vaccination rate. So let's look at some terminology. And again, these are very simple definitions. An antigen is a protein or an invader that the body uses as an identifier. So it recognizes the invader the next time it is introduced. An antibody is a protein the body produces in response to that antigen. So when that antigen is detected again in the body, the immune system covers that antigen with antibodies, which attracts the appropriate cells to the area and directs the attack on that invader. There's a lot of different kinds of vaccines out there, and they all have their benefits and their drawbacks. Live attenuated virus is a weakened form of a live virus. They take the virus, they isolate it, and they find the weakest ones, and then they propagate those and they make vaccines out of them. The benefit there gives you lifelong immunity. The drawback is that not everyone can receive it, because if you have a compromised immune system or you have some sort of infection risk, we can't use the live virus on you. And they don't store or travel well. They need to be kept chilled. Examples of that are a lot of our childhood vaccines: MMR, rotavirus, smallpox, chickenpox, and yellow fever. Then there's inactivated, and that's a dead virus. The benefit of that: no risk of infection from a dead virus. The drawback: it doesn't provide lifelong immunity, and you're going to need boosters. Hepatitis A, the flu, polio, rabies, these all need boosted at some point. Subunit, recombinant, polysaccharide, and conjugate use a specific piece of the virus and not the whole virus. The benefit there: no risk of infection. Nearly everyone can get them. Might not provide lifelong immunity. Probably going to need boosters. Examples of these are some of our more modern vaccines: influenza B, hepatitis B, HPV, whooping cough, pneumococcal disease, meningococcal disease, and shingles. Toxoid vaccines. The toxin separate from the bacteria, the toxin that the bacteria creates, that causes the body's immune system to target the toxin and not the bacteria itself. Benefit, no risk of infection, so nearly everyone can get these, but it does produce a weaker response and boosters are often needed. Diphtheria and tetanus are two of the most common vaccines of this kind. DNA vaccines, introduced into certain tissues to trick the body's DNA into creating antibodies against an antigen. There's no risk of infection, nearly everyone can get them. Provide strong long-term immunity. Drawbacks are it's still in development. The efficacy and safety are still being tested. When I give this talk or talk about any of these, I like to brag about my sister a little bit. My sister is a leading researcher in DNA vaccines, and in her little circle is a pretty famous person. So my family's pretty proud of her. Recombinant vector vaccines. A harmless virus or bacterium is altered to contain the antigen of infectious organism, causing the body to produce antibodies against the infectious organism without actually causing the infection. Doesn't that sound great? That sounds like the perfect vaccine. There's no risk of infection. Nearly everyone can get them. Theorized to provide strong long-term immunity, but it's still in development. It's still in its earlier stages of development. So when we go and get our vaccines, and a lot of us have been through this recently, right? There's always going to be side effects. 1 to 4 days of malaise, localized tenderness, swelling, fever. Sometimes it can be more serious, some fever-related complications, especially in the extremes of age. Allergies, sometimes that's when you find out you're allergic to something, or infection at the injection site. We would hope that good aseptic technique would prevent that. But I'll go into COVID a little bit here. Talking with everybody over the COVID vaccinations over the last couple of, years now, I guess it's been, some people had some pretty serious side effects to it. Personally, I felt like absolute crap after my second shot of Moderna for about a day and a half. But seeing what everybody's going through in our emergency department and seeing friends and family and everybody else get sick, you know what? I'll take 36 hours of not feeling so good. Prior to COVID, one of the bigger outbreaks we had in the United States a couple of years ago was measles. And at the time I'd done these slides, honestly, 28 states had confirmed. And I believe this was over 1 month. No, at that point in Ohio, measles had not broken out in Ohio as of yet, but it did. It did in the end. It did hit the Amish communities pretty hard in Ohio because they don't vaccinate. So this was kind of prophetic. Though measles is the current issue, we can expect other diseases to reemerge. A school system in Berkeley reports that 29% of kindergartners enrolled in 2017-2018 were vaccinated. 29%. Again, I'm not here to argue for or against or try to change your mind in any direction about vaccines, but 29%, that's just dangerous. At-risk populations for measles, the elderly, the immunocompromised, infants and newborns, and pregnant people. A lot of people would say about the measles, it's no big deal. It's just a rash. It goes away in a couple of days. And you know what? Most times that's probably true, but not always. Measles is caused by a virus. Initial symptoms around 1 to 2 week duration: fever, runny nose, cough, red eyes. Sometimes the red eyes are very, very dramatic looking, like holy moly, and usually a very, very sore throat. The later symptom is the rash, which usually starts at the face and neck and then spreads rapidly to the rest of the body. Measles has a pretty distinctive rash too. I'll show you a picture here in a second. So measles is just a rash, right? Just a rash and a little fever. Well, that's not necessarily true. Ear infections with hearing loss, 1 in 10 children. Diarrhea, 1 in 10 children. Pneumonia, 1 in 10 children. Encephalitis, 1 in 1,000. here's the trick with measles. That encephalitis might occur 7 to 10 years after having the measles. So, that's pretty serious. Death 1 to 2 per 1,000 children. It tends to cause premature and low birth weight babies, and 1 in 4 of those will end up hospitalized. That's measles. I don't know. I'll take a shot because that looks terrible. That does not look like any fun at all. Am I right? That makes me itch just looking at it.
Yeah.
Rubella. You don't hear a lot about rubella, but it's out there. Again, it tends to be in the Amish community a little bit too. Also a viral, about a week of low-grade fever, sore throat, pink eye, and rash. That rash usually starts on the face and then spreads to the rest of the body. But there's some serious complications with rubella. Miscarriage, birth defects. It's a big one for birth defects. Getting it when you're pregnant is a problem. Causes a lot of cardiac issues, blindness and deafness due to nerve damage, intellectual disabilities, and liver and spleen damage. And that's rubella. A little more lacy, not quite as well defined as measles. Mumps. If anybody out there has ever had mumps is a miserable couple of weeks. It's viral. It's also on the rise in the U.S., probably because of reduced vaccinations. I imagine people are like, who the heck gets the mumps? I'm not getting that shot. And then you get the mumps. So about 2 weeks, fever, headache, muscle aches, fatigue. Then after a few days, swollen salivary glands, very puffy cheeks, tender, swollen jaw. Usually pretty dramatic presentation with mumps. And this is another one that people say, well, you're just sick and then you get over it and everything's fine. Yep. Unless you have severe inflammation of the testicles. I don't have any pictures of that particular thing, but I've seen some pictures of it, and holy moly. Inflammation of the ovaries, pancreatitis, encephalitis. Encephalitis and meningitis are pretty common with mumps, and those a lot of times lead to deafness. The inflammation of the testicles oftentimes will lead to infertility, as well as with the ovaries. And this poor little thing looks like a chipmunk. That just looks sore, doesn't it? That looks like it hurts. Meningitis. Meningitis is I don't want to call it a catch-all, but there's so many things that can cause meningitis. And meningitis is just inflammation, right? So there's a lot of different things that can cause inflammation. Bacteria, viruses, fungal infections. Fungal infections can be very, very severe, and fungal meningitis is a terrible diagnosis. My favorite, parasites. Something about parasites gives me the willies. Amoeba. You see every year you'll see someone goes to a water park or something and ends up with some sort of amoebic infection, and ends up with meningitis or encephalitis. And of course, meningitis can also be caused by different cancers, head injuries, brain surgeries, things like that, anything that's going to interrupt that integrity. There are some vaccines available for bacterial and some viral sources. Meningitis can be a very, very, very serious infection, folks. Very serious infection. 1 in 3 people who get meningitis will have some sort of permanent disability. That's a staggering fact. In the pregnant woman, miscarriage and premature delivery, stillbirths, life-threatening infections. These people with the meningitis and everything then become severely septic. That's a double-edged sword that's just very hard to beat. Recurrent seizures, we can see why with that irritation in the brain. Hearing and vision loss, chronic coordination, movement, behavioral, or intellectual problems. I don't know if any of you remember, but a couple of years ago, there was a cheerleader, a very, very pretty girl, and she was viral on Facebook and other social medias because she had this very ataxic gait. And what happened to her was she got bacterial meningitis, and that's what she ended up with. If any of you remember that video, and I believe she was even on like Dr. Phil and stuff, she could only walk normally, or not even normally, she could only really get around by walking backwards, because when she would walk forward, her gait was so ataxic that she'd go side to side and fall down sometimes. A lot of times meningitis comes with these little lesions. They might look a little bit like chicken pox, but notice how they're more open than chicken pox. So speaking of chicken pox, it is a viral disease. Signs and symptoms, 4 to 7 days of duration. A lot of times with chicken pox, you get a very high fever. Whoops, I didn't mean to do that. Fatigue, loss of appetite, headache. The headache with chicken pox can be very, very severe, and can even lead to meningitis. The infection can actually lead to meningitis, so we have to be careful with that. Blister-like rash, first on the chest, back, and face, and can spread to the mouth, eyelids, and genitals. Now, chicken pox is one that, it's usually a pretty minor deal. When I was a kid, I remember very distinctly, my friend got chicken pox, and everybody in the neighborhood went over their house and got chicken pox at the same time, with the theory of herd immunity. Of course, that was in 1973 or 4 or something. I don't think we really do that too much anymore. One of the bigger problems with chicken pox is when adults or adolescents get chicken pox. It can lead to some serious complications. Very painful for adults. They tend to get it worse. My old partner at Brookfield, he got chicken pox as an adult. He was probably around 40 years old. And the only way he could sleep, honest to God, was he got a pill bottle from one of the meds that he had, and he could balance his forehead on one spot where he didn't have any lesions, and that's how he was sleeping. So very painful. Can also lead to sterility. So there can be a lot of infection-related complications. The varicella zoster virus stays in your body permanently and lives near the spinal cord. That's why shingle sores start posteriorly and work their way to the anterior almost every single time, and you'll usually find them in one hemisphere. Once dormant, it waits until the immune system weakens with age, chemotherapy, HIV, even very stressful times in life will trigger a shingles outbreak. I can tell you from personal experience, extreme pain. It hurts. There's no doubt. There's a real chance of blindness or deafness if those sores can reach your face and get to the cranial nerves. People don't realize it can cause necrosis of the bones, a chronic neuropathy, you never recover from the neuropathy, and muscle death. Wait, I thought chicken pox was no big deal, right? Chicken pox can be a huge deal. Usually not, but it can be. And this is what chicken pox typically looks like. Sometimes it's way worse, sometimes it's not as bad. Excuse me. Shingles. That's how you're typically going to see a presentation of shingles. They'll usually present along a dermatome, starting in the back by the spine and radiating around to the front, and usually do not pass the medial line. Shingles on bilaterally or circumferentially around your body is serious. Hepatitis. We deal with a lot of hepatitis. Way back in the days when when HIV first started rearing its ugly head, EMS was all into Twitter about HIV, and then we found out that tons and tons of EMS providers had contracted hepatitis, B or C throughout their careers. So hepatitis A, weeks to months duration. There is a vaccine available for hepatitis A. There's about 4,000 new infections a year, likely increasing due to increased drug use. One thing about hepatitis A, and if you're ever thinking about starting to do IV drugs recreationally, hepatitis A is spread by fecal matter. So drug use increasing hepatitis A cases tells me that there is fecal matter in your drugs or on your syringe or in your technique of cleaning yourself. So, ew. Hepatitis B ranges from weeks to a lifetime in duration. There is a vaccine available. There's about 21,000 new infections per year, and it's a leading cause of liver cancer. 50% of the people in the Hep B with Hep B in the U.S. are Asian. Hepatitis C ranges from weeks to a lifetime duration. A leading cause of liver cancer, 41,000 new infections per year. 75% of Hep C cases were born between 1945 and 1965. Hepatitis A is spread by fecal matter or food or objects contaminated by fecal matter. Hepatitis B, spread by blood exposure, semen, vaginal fluids. Hepatitis C, by blood, by contaminated organs or blood during transplants and transfusions, and vaginal fluids. So there's pretty specific ways that these illnesses spread. The big concern with EMS back in the day when we were was the hepatitis B and hepatitis C from blood exposure and other bodily fluids. So one of the problems with hepatitis is a lot of people don't even have symptoms and manage to spread it around. They never even know they have it, and they're just a carrier. But your symptoms may include fever, fatigue, loss of appetite, nausea and vomiting, abdominal pain, dark urine. The dark urine and a lot of times with a very distinctive smell, a very strong smell. Light or clay-colored stools, jaundice, and joint pain. If you look in the mirror one day and you're like, man, my eyes look a little bit yellow, that should probably be a clue to you. Hepatitis has a lot of complications, including in liver cancer. It's one of the leading causes of liver cancer. Pertussis. So back to my sister, who's the geneticist. One other thing I like to point out about her is, as a child, as a baby, she almost died of whooping cough. I'm the youngest in a family of 8. I wasn't even around when this happened, but she spent months and months in the hospital. She was very, very ill. So I'm glad she made it. It's bacterial and it's spread by coughing and sneezing, which stinks because it makes you cough so much. So you are just a bacteria bomb. And it's back on the rise in the US because of vaccinations. Signs and symptoms: 1 to 2 weeks is a mild cough and fever. Babies may present with periods of apnea. But as it starts to progress, actually it's starting to go away a little bit. Violent coughing fits, often leading to vomiting and full body exhaustion. That's how bad this coughing is. So the complications, apnea, I would call that a complication. Hypoxia and dehydration. Let's see if I can get this up. We're not going to watch the whole 226. All right, well, the sound didn't work very well, but it was whooping cough. Diphtheria is bacterial and it's spread by coughing and sneezing. Signs and symptoms: weakness, sore throat, fever, swollen glands in the neck, very sore. Thick gray coating in the nose, tonsils, and larynx. Very distinctive. Very, very distinctive. And causes some severe respiratory distress. It's another one where people are like, oh, it's no big deal. You get sick, you get better. And most of us do, but some of us end up with heart damage and neuropathy and irreversible renal damage. And that looks pretty uncomfortable. So influenza. At the risk of starting a controversy, why aren't we seeing the influenza cases that we usually see? I'm going to go with, because a lot of people are wearing masks, and it's very possible that some are misdiagnosed and whatnot. But I think a big deal is that more people are cognizant of masking, more cognizant of hand washing because of what's going on. Influenza A is the most common. There's a ton of subcategories. We know that it's constantly evolving because we have to get different shots, right? And influenza A is the most severe. Influenza B is less common. There's no subcategories and it's less severe. The influenza vaccination programs, I've gotten my flu vaccine pretty consistently over the last 5 or 6 years, but prior to that, I was pretty spotty. And I only ever got the actual flu once, and it was horrible. It was horrible. What a lot of people say, oh, I've got the flu, is not the flu. It's a stomach bug or something along those lines. So what are our signs and symptoms? We all know that signs and symptoms: fever, severe cough, sore throat, rhinorrhea, muscle and body aches, fatigue, vomiting, diarrhea, respiratory distress, all that good stuff. Usually when I have all this stuff, I wait till about 3:30 in the morning and then call 911. But it can lead to a lot of complications. Sometimes people just get the flu and get better, and sometimes you don't. Severe dehydration, pneumonia, myocarditis, encephalitis, rhabdo. These are serious complications. And we're seeing some myocarditis and stuff like that with coronavirus, right? So the flu vaccine, typically a 3 or 4 strain flu. The strains are chosen based on endemic monitoring. Which strains are spreading the fastest this year? And hopefully they get it right. The flu shot is done with an inactivated virus, and you cannot get the flu from the flu shot. Do sometimes people get the flu right around the time they got the flu shot? Sure. But it's probably from prior exposure. It's not from the shot. So we want to make sure that we get the shot before the flu starts spreading to lessen the risk of this occurrence. And now you all might have heard of COVID-19. And again, this is not a talk on COVID-19 in particular. We've all been inundated with information on COVID-19. I'm not sure I can give you anything more than you've already read, experienced, or researched yourself. So signs and symptoms: fever, cough, malaise, dyspnea, cardiac, headache, loss of taste or smell. We all know that the fever and the taste and smell seem to be like the linchpin symptoms, and severe congestion. That said, I think we've learned over the last year and a half that there might be about 9 million different signs and symptoms of COVID-19. I refer back to, I think history will judge us. I think history will also judge this particular virus, because I don't think we're done with it. When we look at our long haulers and stuff like that, what's the long-term prognosis for these folks? Are they going to deal with this for the rest of their lives? Is your taste or smell ever coming back? That's Like my son would say, I guess that's a problem for future me. The signs and symptoms last days to months. We've all talked with each other. I think I had COVID. I was okay in a couple of days. And then I also know people that I've never seen again. So really a tricky disease. And the signs and symptoms vary widely with different patients. So what are the vaccines? The Pfizer vaccine is 2 shots, 21 days apart, and then a booster after 5 months. And probably, let's be honest, and probably another booster at some other point if this keeps dragging on. It's made with messenger RNA. mRNA teaches our cells, this is way oversimplified, teaches our cells how to make a protein that triggers an immune response. Moderna, 2 shots, 28 days apart. Moderately or severely immunocompromised should receive a 3rd primary dose 28 days after their 2nd shot. It is also mRNA, and we're finding out requires a booster after about 5 months. And again, like I said, if this drags on and on and on, and typically pandemics historically have lasted 3 years, you're going to need another booster. Johnson & Johnson. I don't endorse or not endorse any of them, but we thought it was going to be great. It was a 1-shot deal, maybe. Now they're telling you that you should get an mRNA booster after 2 months. This is a viral vector vaccine. Uses a modified version of the virus to deliver instructions to our cells. The modified version is called a vector virus. So how can you, as a first responder, ensure your safety when you're responding to a patient who you suspect has an infectious disease? So anybody who comes into my ED with their PPE worn incorrectly is sick of hearing this, but your PPE is important. Your PPE has to be there. It has to be in place. It has to be the appropriate level of personal protective equipment. Still seeing way too many EMS crews coming in with improper or no PPE. All I can do is ask you to take it seriously. Wear your N95s. If you don't have the equipment that you need, you come see me and I'll make sure you get the equipment you need. I think as paramedics and EMTs, we've always been pretty good at hand washing. I would certainly hope so, and decontamination. I would really hope that we're good at that we take it seriously, that we nook and cranny those trucks, that we wash our hands appropriately, we get under our fingernails, all these things that we've heard, over the last couple of years. Antimicrobial sprays and gels. When COVID-19 first hit, I saw a lot of you come up with some pretty ingenious deals to help disinfect and clean your ambulances and clean your equipment. Very inventive on some of them. Very inventive. To protect ourselves, vaccinations, including your boosters, and ensuring your past vaccinations are still adequate via titer tests. We don't do that enough. I can't remember the last time I had my titer checked on any of my stuff, but I was just talking to someone the other day who had to get their titers done and found out that some of their vaccines hadn't taken, and as an adult they got to get redone. Limit our exposure to infected persons. That's pretty tough because they call us to their house and then we drive around in a metal box, right? But we can limit our exposure. We can limit our exposure with proper PPE, with a well-fitting N95, by wearing our gown, by protecting our eyes, by wearing our gloves, by doffing and donning our equipment properly. Too many times I see people, that they do wear their gown and then they come out of the room and they just grab it and rip it off. But you know what I mean? There's a very specific way to don and doff this equipment, and we should be good at it. And we should be experts at it by now. But yeah, we want to limit our exposure as much as we possibly can. So the Ohio EMS scope of practice will allow paramedics to administer influenza and other vaccines now. COVID-19, obviously, we've done a lot of vaccination clinics and whatnot, to firefighters, EMTs, AEMTs, and paramedics. And the governor declared state of emergency that affects the public health. It allows EMRs, EMTs, AEMTs, and paramedics to administer drugs and vaccines to anyone, as long as the drug and vaccine is related to the state of emergency and they've had the proper training prior to administering that drug or vaccine. I don't know if George Snyder's on here tonight at all, but he ran our vaccine clinics here in Trumbull County for first responders, and I have to say, it ran like an atomic clock. They did such a great job of it. They trained their people. They got their paperwork ready. They got everything in line. We gave the protocols that they needed and did a great job. Here's my sources: Facebook, Twitter, Instagram, various clickbait. So usually I ask for questions, and believe me, feel free to ask questions, but as I pack up and leave, you can all argue about vaccines. No, but seriously, does anybody have any questions, concerns, comments?
Hey, Matt, it's Lump.
Hello?
Hey, Matt, it's Lump. Can you hear me?
Give me 1 second. You're not coming through very loud and clear. Yeah, go ahead with your question.
Yeah, this is Lump. Not really a question, just a concern I have down in Highlandtown now is our Amish community is growing. I've actually spoke to the bishop of the community about like vaccines and stuff like that because of the concern with the rubella and the measles and stuff like that. And they kind of take the mentality of it's God's will. What happens, happens. They don't really even want to call for help.
Well, you know, one of the things we have is religious freedom and religious, you know, you can be however you want to be. The fact of the matter is, though, that your freedom of religion doesn't free you from the consequences. If they've accepted those consequences, what are we supposed to do? We're certainly not going to force them.
Yeah, that was kind of what I told the guys at the FD. They're nice people to work with. They're really supportive in the community, but they were kind of like, we'll stay on our property and we're not going to call you. So my concern is they do have some small little stores, community stores and stuff that the John Q public is more than welcome to go into it. So it's just something we have to be mindful about.
Yeah. How you been, Lump? I haven't seen you in a minute.
Oh, I'm good. Thinking about
Good.
making my triumphant return to the ambulance.
I'm sorry, I missed that last part, bud.
Thinking about making the return back to the ambulance.
Oh, is that right?
Yeah.
Is there not, who else had a hand up?
Marcia. Do you have a question, Marcia?
I do actually. It's in regards to our young lady that was speaking earlier had brought up a question in regards to, or a subject in regards to what would we do if there was a disaster and we lost electricity or what have you. And we do have an awful lot of the population, not just pediatrics, but adults as well, on oxygen, on vents at home. I guess my question is, who would be in charge of figuring out what would happen during that? I mean, you can't wait until it happens to figure it out. So I guess that's my thought process.
Here in Trumbull County, I don't know how many they have or anything like that. We do have a cache of generators that can go out to people that need them if there were to be a prolonged power outage. And if you were to, in that, like, say you were to experience that in Niles, my first call would be to Niles Fire Department. Hey, we need a generator up here. And my guess would be that they would be there toot sweet.
Well, I can respond to that, actually. That's why that question stuck in my mind. We had a power outage that lasted several hours over the past summer. We had an elderly lady who was on oxygen. Obviously, her concentrator wasn't working. She didn't have O2 tanks. We needed a generator. They graciously supplied one, but I've never honestly had that situation before. So what do you do if that isn't available? Then you transport them to a COVID-filled hospital and make somebody else mad at you. Just saying.
No, I get it. But at that point, you'd be in a real catch-22 at that point. You're going to do what's right for your patient. Was that Niles Fire Department that brought you a generator?
It was, yes.
That's
and they were
awesome.
very gracious
I didn't
about
even know
it.
anything about that call, and I figured, but yeah, I mean, individually, isolated things without outages, my first call would be to the local fire department, get some generators down here.
Thank you. Good job tonight, by the way, even though you're coughing.
The irony of talking about infectious diseases when I'm probably riddled with one right now. Are there any other questions, comments? Nobody? Nobody even wants to argue about vaccines or anything? Wow.
No.
Okay, well,
I would just like to say in regards to the pediatric thing, when it comes to kids with diabetes that we're responding to, and even adults, the insulin pumps becoming more and more preferred as the method to deliver the insulin. So I would just advise everybody to be on the lookout for that. And if you are having issues with hypoglycemia, see if a family member or somebody could show you the way to the suspend delivery temporarily until you can get that fixed and where it needs to be.
that's a good point, Tom. And just like Laura said in the previous lecture, the person to go to is the adult, is the caretaker there. Kids that have appliances, or even something as simple as an insulin pump, the parent is probably going to be an absolute expert on it. And in my experience, I mean, I've had some very critically ill children that we dealt with in our communities and stuff, and you end up dealing with them quite a few times. The parents are well versed, and they're the person that should be making the adjustments and whatnot if they can.
And then tie that into your infectious diseases. My daughter had the unfortunate side of catching COVID from me. And what we saw is that there is an incredible, way worse than the flu, incredible rise in the blood sugars and trying to keep those down and managing them. So just be cognizant of a diabetic patient, especially pediatric, that is exhibiting signs of DKA. COVID probably did a real number on their bodies, and we probably need to look at it instead of going to Trumbull or Joe's, going to Akron Children's or Rainbow Babies for our area.
Tom, do you think that's due to severe dehydration or other mechanisms?
Well, we have a tendency to see it during the flu. A lot of that has to do with dehydration and not really eating. But there is natural chemical changes that occur when they're infected with a virus that tends to keep them on the high side, no matter what. From my experience, I've had more trouble keeping them from going too high than I have from them going low. when she has the virus. So which I would prefer to fight the hyperglycemia, but it's definitely a struggle trying to get that back down to normal. And we usually have to increase insulin doses during those times, and have to call the endocrinologist that's on call to get those adjusted during the time of her virus.
That's interesting. That's interesting. And something else you mentioned, and I'm not telling anybody what to do or anything like that, but when you have a chronically ill child in your community, or someone who these special needs children that have specific issues, even though you might not normally, like, say, go from, I don't know, from Brookfield to Akron Children's, really consider making that trip if that's where that child needs to go. Now, obviously, there's a lot of factors in there with manpower and everything else, but really consider making that trip if that's where that child needs to go, because it just makes everything so much easier for the child, for the family, and everything else when we can take them right to the experts. Obviously, if they're an extremis or something along those lines, we're not going to skip any hospitals. But if the difference for me driving to Akron Children's in Boardman or dropping them off at St. E's, so they're just going to end up going to Akron Children's in Boardman anyway, well, I'm going to take them to Akron Children's.
Hey Larry, I saw that comment in the text. The Omnipod, I believe it does communicate with the Dexcom. It's a very nice enclosed wireless system. The Dexcom also communicates with Tandem insulin pump, which is talking to UH Rainbow Babies is one of the preferred insulin pumps. Medtronic was kind of the groundbreaking insulin pump in developing the quote unquote artificial pancreas type of situation. And they have their own continuous glucose monitor. And that technology out there with the CGMs are insanely accurate for the most part. So if anybody comes across those, 9 times out of 10, from my experience on transporting a patient with a CGM, it's usually way more accurate than the blood stick as long as it's inserted in the right spot.
Cool, dude. Thank you for sharing your experience with us on that. You're kind of an expert on it, huh?
Unfortunately, since she's been 3, so.
Yeah. Anybody else?
Yeah, Matt, it's Joe. Just a quick question, or not a quick question, a quick comment. And it kind of links up with your lecture on infectious disease, and that's a lot of these patients, COVID patients, and so forth, with the influenza being put on steroids. And keep in mind that the steroids have a tendency, especially if they're being done long term, on changing the insulin receptor sensitivity, which has a tendency to push the glucose levels up too. So, somebody's already, prone to changes in their blood glucose level, then steroid treatment would increase blood glucose levels even further. Just a point with the infectious diseases, because we're finding now that a lot of these patients are being put on steroids to, reduce the inflammation and so forth with these viruses.
Yeah, that makes perfect sense too. I guess it all makes sense, huh, Joe?
Absolutely, Matt. Everything makes sense.
All right. Anybody else? Well, once again, I want to thank everybody for spending a couple hours with us. I hope you got some good information from it. I hope it wasn't too painful. We'll see you back here. What is today? Thursday. We'll see you back here on Tuesday, 6 o'clock. I guess that's about it. What do we want to have them do on Tuesday? We should have somebody.
I believe Kristen Woodward's going to talk about behavioral health. She's from the Youngstown VA. And also, we're going to talk about medication administration, I believe, with Matt Gordon. And again, if anybody missed any of the lectures, please make sure that you're enrolled in the Google Classroom that we've created. All the lectures are usually I try to put those up there by the end of the week, following the recording, the upload on YouTube, and the editing. Also waiting on quiz questions from the corresponding presenters. So again, we have over 230 participants registered from various states. On average, we're averaging between 80 and 100 per night that come and go. But there are only like 136 registered for the Google Classroom. So remember, your evaluations for all the instructors are on there, the quizzes to make things up and to show proof that you actually took the class. And again, that end certificate is going to be the NCCP National Registry model that you're going to get at the very end of this. So please make sure you're in the Google Classroom. If you don't have the link, please email us. That's found in the syllabus, or just email Matt and he'll forward it to me and I'll make sure you guys get in. And also on that, we put front and center on the announcement, the Microsoft Teams invite link. A couple people messaged me or put in the chat they had difficulty getting into the meeting today because it wasn't populating their calendar, or maybe they forgot and they had to search through emails. So all you got to do is download the Google Classroom app, get yourself in there, and then right on the announcements tab is the is the Microsoft Teams link and all the announcements that we're making for the class. And then each subject is broken down by links and different various folders in there for you to go and explore. Anyways, thank you to Laura Holdren from Nationwide and Matt, and hopefully Matt isn't too sick for Tuesday. If not, I'll be speaking for him. But everybody have a great night, and if you have anything in the meantime, please reach out to us. And if you have special topics that you want us to talk about, we're filling up the February schedule, which is the special topics, I guess. So we're going to have fire rehab in there. We're going to talk about the importance of active shooters. We're also going to reach out to some veteran firefighters and some EMA stuff, or maybe some incident command. We're having some mental health boards in there talking about substance abuse. I know locally here in the Youngstown area, Meridian Healthcare is on board with us, and they're going to talk about substance abuse and the outpatient clinics and how these substance abuse people relapse. They're also going to talk about Dr. Michael Cafaro, is chiropractor and team athletic trainer for Mineral Ridge Local Schools. He's going to talk about orthopedic and soft tissue injuries for athletes and how to rule those out. So we have a lot of great things coming up. But if there's something that you want to talk about or you want us to get presenters for, send us an email and we'll make sure we do our best to accommodate those special topics.
All right, if everybody's good, have a good night, wash your hands, wear your PPE, take care of yourselves, take care of your families. Have a good night.
I'll be sick Tuesday. I am. So, yeah, I don't think Biz was here the whole time at all.
I think so.